Good morning, good morning, good morning. It is an early cold morning here south of Birmingham. I see a lot of you joining us from the region. We appreciate you checking in with us. I want to address a couple questions already come through in chat. You do not have to sign in with the chat. We are tracking your attendance based on your registration and your login, but I don't want to dissuade you from saying hello, telling us where you're joining us from. I like to see all of the familiar names because I can't see your faces, but I can see your names and appreciate your engagement already. We got 475 of you as of this moment and more coming. So we're going to get started here in just a second. But before we jump into today's wonderful presentation, let's get some housekeeping out of the way. My name is Zach Ludwig, and I'm the Vice President of Clinical Services and Accreditation for Bradford. I'll be introducing today's session and offering tech support and answering questions as we go, along with my colleagues Sherry and Bailey, who are helping out. I want to thank everybody for joining us today. Very topical presentation today related to trauma. Always useful exercise to go through this topic, and especially as we're going to relate it to Bradford's expertise area, and that's substance use disorder. I know that we have a diverse collection of attendees. Some of you from agencies I can see being noted here, a lot of you in private practice or other members of the helping community. So these are great opportunities for us to come together, share some knowledge, and make some of these connections as I see y'all are doing there in the chat. You are viewing this presentation in the webinar format, which means that you can see me and our fellow presenters, but your video and your audio is turned off. Your engagement with us is going to be through the chat, which many of you are already doing, and the Q&A functions. A lot of times, if you're on a computer, these are towards the bottom of your screen. If you hover over and move your mouse, it will pop up with those options. If you want to communicate with us, any questions, concerns, or other considerations for engagement during the presentation, we encourage you to do so. We will try to address questions in real time as they're coming into us, but as you can see, the chat moves pretty fast. If we don't get to you, if you want to put it in Q&A, we're going to make sure we try to wrap up to those by the end of the presentation, time permitting. Few other nuts and bolts. You are going to be receiving a post-survey email. You will be getting materials from today. You're going to get a link to the recording so you can rewatch it or share with your friends. You'll also get a copy of the PowerPoint itself, which will include reference pages for any of the resources that our speakers reference throughout today's training. That is a really common question, comes up a lot. Just letting you know you're going to get the materials. You will be getting an email. If you don't get that email by the end of today, if you want to reach out through the means in which you registered, please let us know. For attending today, you are eligible for 3 continuing education contact hours. Bradford Health Services is providing continuing education contact hours at no charge to you for today's presentation. In that post-session email that I just mentioned, you will have a link to an evaluation. Very important that you complete the evaluation. In order to receive the credit, we have to receive an indication that you attended today. That's by you registering and being here in the room with us for the full 3 hours. That, along with a completed evaluation, is what creates that certificate for you. Certificates will be emailed to you once you complete the evaluation. If you would give us a couple of weeks at most to get those out. If 2 weeks from now, on the 20th of December, you have not received a CE evaluation, please reach out to us. It does take us a little bit of time to go through those, and we have a lot of people attending already, now over the 600, so you can imagine this is quite a lift for our staff. One rock star staff member we have processing these out. If we experience any technical difficulties today, really hoping we don't, Weather looks beautiful other than chilly, but just in case something happens. If it's on our end, we are going to attempt to get back into this session using the exact same registration link that you used to get into this room right now. If that takes longer than expected or just impossible to resolve, we'll be sending out an email that'll explain the situation and what our options are. A lot of that's going to depend on how much of the session did we get through. Were we nearly finished? Were we halfway through, or did it happen moments from now? That will dictate our ability to do makeup sessions or provide partial credit. All right, I think that's got a lot of the housekeeping covered. So let's move into introducing what we're going to be talking about today. Very excited about today's session titled Addressing Trauma and Substance Use Disorder Treatment. We have two excellent speakers with us today who are very knowledgeable about this topic. They will share information on trauma and the treatment strategies when working with clients with substance use disorders who have also experienced trauma. I'm going to briefly introduce those speakers at this time, but they will both be giving you some more specifics about their backgrounds and experience when each of them takes over in turn. Our first presenter is going to be Ashley Phelps. Ashley serves currently as our Director of Therapeutic Intervention Training and is a multi-state licensed social worker, and she's worked for Bradford for over 6 years. Our second presenter, after about midway through today's time, will be Leah Parker. Leah serves as our clinical director at our Tuscaloosa PHP program, which provides support for those who are residing in our Reprieve level programs. She's worked for Bradford for more than 12 years. We have a lot of experience talking to you today. Both presenters will be available during the presentation to answer questions through the chat and the Q&A as time permits, and hopefully we'll have some time to do a little panel discussion at the end. I hope you enjoy today's presentation. At this time, I'm going to turn it over to our first speaker, Ashley Phelps.
Good morning, everyone. So as he said, I'm Ashley Phelps, the Director of Therapeutic Interventions Training here at Bradford. I have worked in several different roles at Bradford, counselor at inpatient, the IOP level and OP programming, and that is in Alabama and Tennessee. And then I also served as clinical director in our outpatient office, one of our outpatient offices. So a lot of different roles that I've been in within Bradford over the course of 6 years, going on 7. So today I'm going to discuss aspects of trauma. We're going to look at the definition of trauma and also the prevalence of trauma. Additionally, we're going to explore the relationship that is present between substance use and trauma. So those are our objectives today. So when we're looking at trauma, of course, there's several different definitions out there, and of course, everybody's perception regarding what trauma can be different. It can vary from person to person. However, this is the most universal definition that is present in research and just various things that are available to you regarding trauma. So trauma is going to be an event or a series of events or a set of circumstances that are experienced by an individual. The experience in the event is perceived as being physically or emotionally harmful or threatening to them. And of course, the trauma results in adverse effects to their functioning, and that's on a mental, physical, social, emotional, and spiritual level. So when we're looking at just kind of this slide, you see that there's emphasis on 3 different words. And so the emphasis is placed on event, experience, and effects. And so these are known as the 3 E's of trauma. And so that might be a good way for you to kind of recall and remember the definition of trauma and the different aspects that go into defining what trauma is. So we're going to look at those individually. So the first one's going to be events. And so this can be an actual or extreme threat of harm. And so this is a perception based upon the individual. And I say perception because the event could be something that's happened directly to an individual, or perhaps something they may have heard from someone else, or even something they may have seen on TV. So all trauma and stressor related disorders do require the inclusion of an exposure to a traumatic event. And of course, that exposure is going to come from the perception of the individual that has experienced a trauma in some way. Again, mostly just recalling that the event is something that they perceive as threatening to their safety. So the second one is going to be experience. And again, this is going to be based upon the perception of the individual. And this is the experience is utilized to determine if it is a traumatic event. And contributing factors include the individual's physical and psychological disruption, but also just the meaning and that they attribute to the event that they are experiencing, and the labels that they may assign to the event, which again is person to person. So this might, you know, be something that's happened, and one person might perceive it as traumatic, whereas the other person might not. So it really is individually based. Typically, when trauma occurs, there is a power differential that's created between, the person that is traumatized and perhaps the person or the event that is traumatizing. And so the way the event is experienced is influenced by several different factors. And so some of those factors we will address in a later slide. And the third E of trauma is effects. So in other words, what are the physical and psychological impacts that occur within the individual following the event and the experience that they've had? So the effects could be something that you see right after the event. It could, coincide with the event, or it could have a delayed onset. So traumatic effects might occur, months or even years after the experience. The effects could be short term. So, over the course of, a couple days, a couple months, or long term going into years. So examples of the effects that can occur is impaired functionality with daily stress. They might present with a lack of trust in a variety of relationships that they have in their life, difficulty with memory, and also just difficulties with emotion regulation, and also expression. And the makeup of their neurobiology could be altered, and we'll touch on some biological effects of trauma in a later slide. So looking at types of trauma, I'm pretty sure that most of us have heard of chronic trauma or complex. So there is a difference between the two. So your acute trauma is going to be something that is singular, a trauma that might be brief in nature. An example of this would, of course, be the something that occurs in one point in time. This could be, for instance, a loss that a person experiences of a loved one, or even a pet, for instance, could be a single acute trauma. Your complex trauma is going to be exposure to repeated or prolonged trauma. This is typically repeated trauma that happens, so series of traumas that occur over a period of time to the same person. So this might present as repeated physical abuse, for instance. And then our sustained trauma is going to go into the chronic, which is a combination of acute and complex. And this is traumas that might occur over a longer sustained period of time. So happens over a longer period than perhaps the repeated. So this might be an individual that experiences ongoing physical abuse throughout their childhood, or even chronic poverty would be part of this sustained chronic trauma. So looking at examples of trauma, trauma can be a natural occurrence. It could be something caused by humans. So our natural occurrence is things like natural disasters, um, could be, for instance, tornadoes or hurricanes, anything that might be related to perhaps weather can be examples of trauma. Any type of abuse that an individual might experience. I know that physical, sexual, and emotional abuse is listed on the slide, but it would also include neglect, financial abuse. So any type of abuse that an individual could experience could be considered trauma. Bullying, that can also be trauma, whether that be bullying in person or perhaps through the technology that we have nowadays. Any type of community violence that a person sees or is exposed to or even experiences firsthand. Traumatic grief. There's also trauma related to medical experiences. Vehicle accidents can also result in a trauma response. War-related trauma, which is typically what individuals think of when they hear trauma, as war-related trauma or abuse. However, other things, as we've seen, are part of trauma. It could be historical or cultural trauma, race-based trauma, and then, of course, secondary trauma can be part of an example. So a little bit on the statistics, and these were definitely unsettling when I was looking at the statistics related to trauma. So when we're looking at worldwide, it's approximately 70% of people who've experienced at least one lifetime trauma. And then of that 70%, 31% being exposed to 4 or more in their lifetime. And then in the US, specifically, that number does increase. However, keep in mind that, of course, research might vary a little bit, but approximately 90% was listed for people who experience one lifetime trauma. So higher number of women report direct interpersonal violence, so looking at domestic violence, for instance, sexual assault, and that can include sexual assault and also sexual abuse, was reported more by women, and then physical assault, which could explain the differences between women and men, and why their numbers regarding trauma and also the development of PTSD is different. So women are 2 times more likely to develop PTSD compared to men. And that, again, could be explained just because women report higher rates of domestic violence, sexual assault, physical assault compared to men. Men tend to report experiences such as physical assault, however, not necessarily related to domestic violence. Combat, accidents, disasters, and or witness death and or injury. So those were more specific to men as compared to the other areas that were more specific to women. And then another kind of prevalence that was reported is that PTSD has the highest lifetime prevalence within the Black community, And again, based upon research, this is because of various experiences that individuals might experience in their lifetime. So next, we're going to look at some statistics related to post-traumatic stress disorder. And this you might hear referred to as PTSD. So these statistics were also unsettling to view and to see kind of written out. So in their life, there was approximately 6%, 6 out of 100 people who developed PTSD. However, in the US, which was surprising because of the previous statistics based upon trauma, there was estimated to be 5% in a given year that developed PTSD. However, the first one was more specific to lifetime, whereas the second one was more specific to just a given year. So that varies from year to year. In 2020, we saw about 13 million Americans that were diagnosed with PTSD. And the number of PTSD are higher, or the numbers of diagnosable reported PTSD is higher in women at 8% and men with 4%, which makes sense when we look at the previous trauma statistics and see that women typically report different experiences compared to men, but also other variables are present when we're thinking about PTSD development, and that goes back to the definition regarding the meaning that someone might attribute to their experience, and also just their perception. And there's additional variables that we do look at in a later slide. So what is a way that we can kind of pinpoint? I know that in the previous slides we looked at, one or more or four or more traumas. So what is a way that we can kind of gauge that, and what is the most used type of assessment in this research? And that is going to be our adverse childhood experiences, which is also referred to as the ACE. So the adverse childhood experience does come from a medical study that collected data from 1995 to 1998. And that measured certain childhood experiences that individuals might encounter from during the first 18 years of their life. And this study actually sampled 17,000 people. And there was, I was unable to find the original study because a lot of research articles report that this is actually an ongoing study that they are doing. So this was a breakthrough for really understanding the connection that's made between childhood stress, trauma, and also health. And that's helped, physically because of the effects that trauma can have on an individual, and also just like how our brain develops if we're exposed to childhood stress and trauma. So the ACE does ask 10 questions, and this is related to childhood abuse that they might be exposed to. The areas that are addressed include areas such as physical abuse that they have witnessed, neglect that they may have experienced, sexual abuse, physical abuse, divorce and separation of parents, and also physical substance use, incarceration, and or mental illness that they may have seen in childhood or been exposed to. So a few different areas that the ACE does assess, but overview, those are a few of the areas that the 10 questions do touch on. So a lot of information can be obtained just from this short assessment. So the experiences based upon the original study actually linked these experiences to an increased risk of risky health behaviors, chronic health conditions later in life, low life potential, and also early death. So additional information is ACEs have been connected to a change in neurodevelopment, which can lead to an individual with emotional deregulation, sensitivity to substance that reinforce and reward. And that is also connected to the biological aspects of changes that an individual can experience, which I do expand on more. So in 2019, 5 out of the top 10 causes of death were related to the ACE, of course, specific to the US. Of course, this has changed over the last few years since 2019 due to other issues arising, such as COVID, which has moved into the top 10. So it has changed a little bit since 2019. However, in 2019, it was 5 of the top 10, which I thought was interesting and, of course, unsettling. So approximately 16% of individuals do report 4 or more ACEs in their lifetime. And a study conducted by Barthlow and Huffman actually report findings from the original ACE study, which suggests that having or reporting 4 or more ACEs had a 500% risk of developing alcohol use disorder. And 6 or more ACEs reported correlated with a 4,600% increase of injected substance use. And additionally, 4 or more has been linked to higher risk of suicide. So definitely some unsettling statistics related to trauma and just the connection with the ACE. Definitely a big issue, of course, in our community and, of course, in the U.S. and worldwide that could use some attention and education. So additionally, CDC research suggests that 64% of U.S. adults have experienced at least one ACE, and so that definitely explains some of the differences between research, but still a very unsettling number with 64% expressing at least one that they've experienced. So the more ACEs that are reported in a person's history, remember that they are more likely to engage in risky behaviors. And those risky behaviors are, of course, substance use and smoking, and also sexual activity with multiple partners or engaging in sexual activity early in their life. It puts them at higher risk for developing medical problems, and this can include diseases related to the heart, liver, and lungs, and also puts them at a higher risk for sexually transmitted diseases and or infections. And that's for a variety of different reasons. For instance, injection of substance use could, of course, increase their risk of sexually transmitted diseases, but also just the point with increased sexual activity could also put them at risk for that. So that is due to several different factors. It also creates a risk for poor academic achievement and also a decline in their work performance. It can contribute to an increase in financial stress, intimate partner violence, sexual violence, unintended pregnancies, and also early death. So the big question today is, how does trauma and substance use go hand in hand with each other, or work hand in hand with each other? So trauma as well as substance use does drastically impact a person's brain, and this can be in several different ways. We will look at just a few today. Of course, the terminology associated with the brain and also just health or anatomy can be difficult, so I'm going to try to explain it in the best way that I can. So looking at trauma in childhood, this can weaken the connection between an individual's medial prefrontal cortex and the amygdala, which I'm sure we have heard of the amygdala a time or two, and also the prefrontal cortex, just working in perhaps a counseling session or even substance use and how different things affect our brain. But expanding on these terms a little bit further, the medial prefrontal cortex is a section found in your frontal region of the brain. So the area where your forehead is your frontal lobe, frontal region. So of course, the medial prefrontal cortex is not at the very front of your forehead, but it is back a little bit. But this area is widely connected throughout the brain, and so it's involved in a lot of different functions within the brain and the body. And a few of the functions relate to executive functioning, interpretations of an event, and as we've discussed earlier, trauma is in a sense regarding interpretation and perception of an individual. And this area of the brain also it plays a part in suppression of negative emotions and also the regulation of reward circuits. So this area, the medial prefrontal cortex, typically has strong connections to the amygdala, which is located in a person's temporal lobe of the brain, which is on the side, right around where your ear is. And this region of the brain creates feelings, and those feelings can be anything from anxiety to fear to anger when it is activated. And then trauma can weaken the connection between the medial prefrontal cortex and also the amygdala, which can make an individual more susceptible to negative emotions and also dysregulation over those emotions. So this has been shown to increase risk of multiple substance use disorders and also a greater reduction in this connectivity that is found in the brain, which increases a person's risk to return to use. So continuing further into this, individuals with childhood trauma and individuals in this particular research was specific to cocaine or heroin use. And this has shown an increased connection between the medial prefrontal cortex and the ventral striatum. And that is located deeper in the brain near the center, so it's not part of the frontal or the temporal lobe. And this is a region which is involved more in the monitoring for and responses that an individual might have to rewards. And so this increased connection between the striatum and the medial prefrontal cortex appears to reflect stronger reaction to cues, suggesting that a possible reward and increased motivation to attain substances. So when we think about this, an individual, of course, they're getting some type of reward because it's, in a sense, helping with their emotional regulation and their ideal of coping in some way. But also, increased motivation to attain so that they can have that experience. And so this can help of course, increase their dopamine when they use a substance, dopamine in the brain, which can contribute to a reduction in their negative emotions and opens up the reward pathways. So additionally, the first 2 points, the ventral medial prefrontal cortex becomes active with fear extinction recall and recall of addiction cues. And this particular research was more specific to cocaine use. When it experiences cravings of cocaine, the ventral medial prefrontal cortex does become deactivated, leading to a failure to engage in extinction. So in other words, these first 2 points mean that when a person's ventral medial prefrontal cortex is active, an individual recalling or remembering cues associated with their addiction, so in a sense, the positive aspects, they're also activating the same region that assists in eliminating the fear response. Whereas when they're experiencing cravings, which is the need and the want to obtain a substance, due to a variety of different reasons. For instance, the negative emotions that increase, this region is deactivated, which increases an individual's fear response. And so, of course, the prefrontal cortex and different regions of a person's prefrontal cortex is involved in drug-seeking behaviors, as well as their extinction of fear conditioning. And then additionally, just with a statistic related to PTSD and co-occurring substance use, individuals with both is approximately 47%. So a little bit more on the brain, and this is going to be more specific to the third point on this slide. So regarding the brain, the part of the brain associated with fear expression. This region is the human dorsal anterior cingulate cortex. And this is also a region, or a region that is located in the frontal lobe. And so this, as with pretty much any part of your prefrontal cortex, is involved in a lot of different functions. And this can include things like control of cognitive functionings, such as monitoring conflict between responses that might be competing, also detecting errors, and it does play a part in reward-based decision making, and so serving as a guide for that process. So basically, this region of the brain is a conflict monitor that assists the brain in navigation of complex situations and deciding on the most appropriate action to take based upon the information received. So looking at a study regarding the lesions that might be found on this area of the brain, and this was conducted by Hellbronner and Hayden in 2017, so a relatively recent study. They found that when lesions are on this part of the brain, it does produce feelings of apathy, so losing interest in things in life, emotional instability, and also akinetic mutism, which is a neurological disorder associated with the inability to speak or move spontaneously. So the functional purpose of fear expression is to signal danger, motivate an individual to respond, and direct their attention. Therefore, if we're looking at just drug-seeking behaviors when an individual is experiencing cravings or a high level of cravings, it is in part due to the individual, due to the brain connectivity and the impact on different parts of the brain, they're being signaled that danger is present and they do need to jump into action and respond, which kind of coincides with an individual that might not be able to get through their cravings and kind of get them to subside with more positive coping skills. This individual, in a sense, might be impulsive, so they might act really immediately when cravings start. And so this kind of points into the brain is really signaling danger being present, and of course, their fear response is increased. All right, so looking at further impacts that trauma can have on an individual. This can present as a variety of different symptoms, and this can affect aspects of an individual emotionally, physically, cognitively, behaviorally, and also existentially. So some individuals might clearly display criteria associated with the post-traumatic stress disorder that we discussed earlier. However, many more individuals will exhibit resilient responses or perhaps brief subclinical symptoms or maybe consequences that might fall a little bit outside that diagnostic criteria, but are still experiencing significant responses that might impact their life in different ways. And of course, these can be immediately present or delayed. So looking at just some of the reactions, of course, definitely not an exhaustive type list, but emotional reactions that an individual could present with, it could be reports of shame and guilt. They might present as more angry or irritable, dysregulation of their emotional response, or might even become detached from their emotions. They might move into a state of denial or withdraw from their settings. And that could be connected back to just kind of losing trust within the relationships that they have. Physical reactions could present elevated heart rate or blood pressure, fatigue. Of course, their startle response might be increased, but they could also have, for instance, sweating or even muscle tremors could be present, nausea. Cognitive reactions, they might have difficulties with concentration, with their memory. They might experience intrusive memories associated with the trauma that they've experienced. And also their decision making. That might be difficult for them. And that can also be connected back to just all that happens within the frontal lobe of an individual when they might experience trauma, and or of course even substance use can factor into a lot of these reactions as well. Behavioral reactions that could be present, of course, they are at higher risk of substance use. They might have decrease in their activity level, might avoid certain things, could be people, places, things, objects that might remind them of their trauma. So going back to the intrusive memories that might be present. And the existential reactions that could present, of course, not an exhaustive list of any of these, but could lose their purpose or report that they don't have meaning or can't find meaning within their life. And this can also be associated with their experience. They might question, why me? Why did this happen to me? They might present with despair regarding humanity and the world. So their worldview can be impacted as well as their view regarding themselves. So a lot of different areas can be affected, And of course, their reaction and outward presentation can be different and change. So looking at the trauma response or trauma reactions, these can be influenced by a variety of different things, which was mentioned a little bit earlier. But these things can be, for instance, the biological makeup of a person. So, of course, brain areas that are involved in our stress response, of course, are the prefrontal cortex, the amygdala, and also hippocampus. So neurochemical systems like our cortisol, norepinephrine, dopamine production, the neurotransmitters can also play a role in the response that an individual has. Looking at the developmental level of an individual, so of course, childhood is a particularly sensitive area when it comes to development of the brain. So looking at when in a person's life did trauma may have occurred, and that could definitely influence their reaction. The severity of the stressor that takes place can also be a factor regarding their reaction. And so looking at the severity of the stressor, of course, that is based upon the perception of the individual and just how it impacts them and the meaning that they attribute to the stressor. Other influences might include like their social context, so the groups that they might be part of, family environment, supportive relationships that they might have can all influence the impact of trauma. Previous experiences that they may have had. So if we're talking about, for instance, earlier with childhood experiences and this individual experiences additional trauma later in life, their reaction or impact of the trauma in the later in life traumatic experience may be the same, it may be different. So that could also be a factor. And then also just things like coping skills. What does this, what interest or hobbies does this individual already have in place can influence, and also cultural norms and just society as a whole that an individual might be part of. All right, so looking a little bit more into biological impact. So with trauma specifically, this does change the limbic system functioning, and this is actually connected to the working hand-in-hand slides from earlier with the ventral striatum. That is linked to the limbic system, and that again is associated with the reward system in the brain. So additionally, the amygdala is also part of the limbic system, and so this can have a strong impact, of course, with emotions, and also the response of fight or flight that an individual has. The hypothalamic pituitary adrenal axis activity, and that is a very long string of words. But this changes with variable cortisol levels. So, the stress response, the chemical that is typically released when stress response is impacted or activated. So again, the early exposure to trauma can impact the development of the brain. And so that can actually impact like structures and also the functionality that areas of prefrontal cortex, the amygdala, and also hippocampus have in the brain. So I thought that was interesting that trauma impact early in life can actually change the structure of different parts of the brain. And then just with the neurotransmitters, of course, an imbalance can occur. an additional symptomology that might be present is hyperarousal and sleep disturbances. All right, so trauma also impacts the memory and also perceptions. And again, an individual's perception is a huge aspect of trauma and the reactions and also the experience that they report regarding meaning that they might attribute to the event. So, of course, impact on memory and perceptions, we're looking at prefrontal cortex and how executive functioning might be impacted. And so that goes back to earlier slides with the different parts of the prefrontal cortex that receive, I'm going to say, damage in some aspect that changes kind of the functionality of those areas. So prefrontal cortex plays a huge role in trauma and also substance use, if we have not heard that yet. So of course, prefrontal cortex plays a role in memory. So neurobiological changes related to emotion regulation, which, again, goes back to prefrontal cortex, but also specific to the amygdala. That can influence a person's perception specifically to like sensory input within the body and also external environment. So that really kind of plays into, trauma is a threat to someone's safety. And so when we're talking about, changes in the brain that may occur when exposed to trauma, of course, their perception and how they receive that stressor in their environment is going to be impacted because of the changes that occur. So looking at, of course, research is very, very specific throughout different research articles regarding prefrontal cortex and the role that plays in emotional processing among individuals with PTSD. And so this can definitely shape the intense reactions to traumatic reminders that this individual can have. So this might be a sound that they might hear that's triggering, any thing that they might see in their environment that reminds them of the event, and even smells. And this can lead to decrease in their control over cognitive functionings of the behavioral responses. And so we got a lot going on when someone experiences trauma and also substance use, because as we've seen, some of the same similar brain functions and structures that are impacted by trauma are also impacted in similar ways with substance use. And so we're having an impact on a variety of different things within our brain, but also our body. So looking at memory, there, of course, is explicit memory and implicit memory. And so there's two different types within each category. And so the somatic memory, temporal and inferior parietal lobe is part of this particular memory processing. So with trauma, it can actually prevent information from combining in different parts of the brain, which can lead to, of course, that lack of, or not lack, but decreased recall memory, but also the extreme reaction that they could have with intrusive memories that could occur. Episodic has to do with the hippocampus in the brain. So memory can be shut down and fragment event sequences. So that could explain, for instance, an individual who has had a traumatic experience but cannot recall the events, or cannot recall certain aspects of the event that took place, or perhaps their memory has spots in it or holes in it, for instance. And then the emotional memory has to do with the amygdala. So, of course, with trauma, we're looking at the triggers that they might face in their external or even internal environment that could increase the painful emotions that they experienced when the trauma took place. And then procedural memory. This, of course, is the striatum that we discussed earlier. And this can actually change memory patterns of an individual. So a lot of things are happening with memory, and of course, each aspect of a person's memory is changed or altered or could be. I'm not going to say this is consistent with every individual, so we're going to say could be altered in some way. So a lot going on in the brain when an individual is exposed to trauma, or a lot could be happening in the brain. And then also a lot happening in the brain when an individual is exposed to substance use, but also develops an addiction to the substances. So looking at some kind of aspects when we're talking about trauma, if trauma is unresolved, and this could be for a variety of different reasons, and it could be, the reactions that they might have. They might have, gone into a state of denial or withdrawal to where they're not going to work through the trauma, or perhaps just the brain functionality that occurs. So a lot of different reasons why perhaps trauma is unresolved and not addressed. And so this can contribute to a lot of things developing. Of course, mental illness, so looking at PTSD, depression, anxiety, a variety of different mood disorders can stem from unresolved traumas, substance use disorders, and also just kind of additionally just addictive behaviors in general. So it definitely is specific to substance use disorders, but also there are other addictions that could develop as well. So chronic physical health conditions, and we talked earlier about just the impact that trauma and also substance use can have on different organs within the body. So we're looking at the heart. Of course, when we are stressed and we have all of those additional chemicals that's being released, it does put strain on our heart. And so if we're looking at a chronic state of that happening, then that can contribute to, for instance, high blood pressure, of course, higher heart rate, which again puts a lot of strain on a person's heart. So that can contribute to physical health conditions related to the heart later on, or even shortly after. Can contribute to issues with liver, lungs, of course, the brain impact. So things could develop in regards to the brain. And then looking at just kind of additionally, which I did not know this, kind of backtracking to the mental illness, unresolved trauma has actually been linked to the development of schizophrenia and other forms of psychosis, which was definitely new to me. I did not know that schizophrenia could potentially be linked to mental illness. So even serious mental illnesses that are present can relate and go back to trauma that an individual has experienced. So trauma, again, with physical health conditions, a variety of different things are being impacted in the body. So even like cancer can be related to unresolved trauma and just the changes that are happening within an individual. And if we're talking about changes in functionality of certain parts of the body, and also the structure and all the additive release of neurotransmitters and just chemicals within the body, it plays a role, or could play a role in physical health conditions that an individual can develop. So negative impacts on an individual, of course, just a little kind of recap. And this is trauma, but also just kind of aspects of maybe dysfunction that an individual can have with substance use as well. So a lot of these, if not really all of these, can coincide with just kind of trauma and substance use together or standalones. So a social impact can occur. Of course, that can go back to the distrust that an individual develops. It could be the strain, perhaps, that their reactions or changes might place on that relationship. It could be withdrawing that an individual might do when they experience trauma, and also substance use. So a lot of different things could happen that contribute to just kind of the negative social impact of an individual. Economic, so it has been connected to just an increase in financial stress, which could be due to the poor work performance that could develop. And that can be traced back to the reactions that they have. So if we're experiencing a lot of physical symptomology, of course, we're not very motivated to engage in our job, especially if our job requires a lot of physical, I guess, strain in a sense, physical functionality. Also, if a person experiences those emotional response, so perhaps they're feeling a lot of shame or anger, of course, that can play a role in their work performance, which could lead to financial stress. But looking back at the first three, economic stress can come from the development of substance use disorders. So substance use disorders or substance use in general is costly. And that could be like treatment, it could be use itself, mental illness. Again, the mental illness itself can prevent us from engaging in work in several different functions and roles that we might have. But also, if we're talking about financial stress related to medications that could develop or even treatment. So negative impacts can go into cognitive functioning, and that has a lot to do with the impacts that we discussed, or a few of the impacts that we discussed related to a person's prefrontal cortex. Of course, cognitive functioning, of course, our brain is really interconnected with a lot of pathways and highways. So, of course, there's impact being done in other areas as well. Emotional regulation, a negative impact. So that could go into just kind of expanding further. Emotional regulation or a negative impact on emotion regulation is tied to some personality disorders. So that emotional regulation that's been impacted, of course, doesn't mean that an individual is going to develop a personality disorder, but the emotional regulation or lack thereof can lead to a personality disorder, especially if we're looking at a lot of, or not even a lot, if we're looking at childhood trauma and just, of course, the brain development that occurs with that, the lack of emotional regulation, we're, perhaps not exposed to healthy emotional regulation, and that could be in part due to the trauma that we've experienced. So emotional regulation can, of course, be a standalone negative impact, but also can lead to other negative impacts that an individual can experience. And that just kind of goes to show, again, just the interconnectivity that an individual has with kind of the brain and the body. And then, of course, normal brain development is going to be impacted, especially looking at the effects that can happen with functionality and structure of different parts of the brain in childhood as they're developing. So a lot of things are going on, of course, in the brain as we're children, because as most research suggests, brain's not fully developed until about midway into our 20s. And of course, uh, according to research, the prefrontal cortex is the very last thing to fully develop. And of course, that kind of is the interconnectivity to a lot of these things that we've talked about today, with especially cognitive functioning, decision making. So that definitely can have a significant impact. And then also, if we're talking about trauma in childhood, that might obviously lead to a higher risk of substance use. So we're also looking at engagement in substance use behaviors prior to that full brain development that occurs. So a lot of things can happen with brain development during that time, or just the impact. And then just kind of mistrust of healthcare system, but that's also mistrust in just relationships as a whole, which was mentioned earlier. So this is going to, of course, impact the social aspect of their life, but it could also impact work performance as well, just because of the distrust that they might have within their coworkers or their boss, or perhaps the business itself might be present. So different impacts that can occur with distrust within relationships, but the significant one is healthcare system, because if we're talking about unresolved trauma, if they've developed a mistrust within the healthcare system, then of course they're going to be less likely to seek out help and assistance with processing trauma or resolving trauma in some way. So that, to expand on that, and that's just the trauma itself, but if we're talking about the chronic physical health conditions that could develop, if they have that mistrust in the healthcare system, then they could potentially be less likely to address those physical health conditions that have developed, which could definitely lead to them worsening over time. So that might be, they're not going to, doctor's appointments or, specialty appointments, but also perhaps not receiving the proper medication that they need to manage those physical health conditions. So a lot of these things, it looks like just one point, on this PowerPoint, but when we really talk through what all this means, we see that there's several different things within a person's life that, of course, is connected, but also impacted. So definitely a lot of things, negative things that could arise due to an individual being exposed to trauma, but also looking at just kind of the connectivity with substance use on this last slide. A lot of these can occur with substance use disorders too. They can, contribute to mental illness, to the development of chronic physical health conditions. Of course, all of the things under negative impacts can be that could happen to individuals with substance use. And then also individuals with substance use disorders can present with distrust in the healthcare system. So definitely some kind of overlap there with unresolved trauma and substance use. So different things can happen with trauma. So it really can impact an individual in several different ways. Of course, each individual is different. So someone might present with a few, and others might present with a multitude of impacts and struggles and symptomology and reactions. So it definitely can just kind of disrupt a lot of functionality within the person's life, but also internally, and how they perceive different things in their life. It can disrupt, how they communicate with individuals in their environment, in their workplace. If we're talking about unresolved trauma, going back to one of the earlier slides, they might have that increased irritability and anger. So if we're presenting in a workplace or social setting, or with family, in an angry way, a lot of the times, then of course that's going to have a drastic impact on that rapport and relationship and connectivity that an individual has or had. So definitely unresolved trauma can lead to a lot of negative things. And so moving forward, I have included references for your viewing later if you would like. And there's two different slides that grab the resources that were used in today's presentation. And with that, that concludes my section of trauma and substance use.
Wonderful. Thank you very much, Ashley. We've had a lot of activity in the chat so far. Thank you all for your engagement. We definitely had a few questions come in. We're making note of those. If you'd like to keep those coming in the chat or the Q&A, if those are not further addressed in our next session with our next speaker, we'll make sure to speak to some of those at the conclusion of today. At this time, though, we are going to take about a 10-minute break while we do a switch over to our other speaker, and that allows everybody a few minutes to stretch your legs and refresh your beverages and things like that. We invite you not to close out of Zoom, but instead just keep the screen up. We will go dark for just a moment where you will not be seeing or hearing anyone, but we are still there. And it is just 10:11 here in the Central Time Zone. We're going to come back at about, call it 10:20, 10:21. And we will see you all back in just a few minutes. Thank you. Welcome back, everybody. 10 minutes just flies by, doesn't it? All right, we are going to move into the second part of our session today with our second speaker. This is Leah Parker. As I mentioned earlier, she's been with Bradford for 12 years, also held some different roles in the organization, working out in Tuscaloosa, Alabama right now, providing partial hospitalization treatment support for those who are in our Reprieve program. If you're unfamiliar with our Reprieve programs, please check out our website, bradfordhealth.com, for information about what makes that program distinct. Leah, I'll let you carry forward with your presentation slides as well as any introduction you'd like to share with us. As a reminder, everybody, keep your messages coming in chat in the Q&A. We got some good questions we are taking note of for our discussion at the end of the day. And we definitely want to make sure that any comments and questions you may be having as we're going through this are being addressed as best we can. So with that being said, thank you, Leah.
Hello, everybody. My name is Leah Parker. I'm the clinical coordinator at the Reprieve. As Zach stated, that is one of Bradford's PHP programs, partial hospitalization. So a little bit about me. I've worked for Bradford for over 12 years. I always joke that I have pretty much done anything you could possibly do within the Bradford system. I've done administrating, clinical coordinating, night groups, long-term residential care, PHP, inpatient. So just kind of running the gamut here at Bradford. So I'm happy to be with you guys today. I've done some training and been trained in dialectical behavioral therapy, cognitive behavioral therapy, and EMDR. So today we're going to be taking a look at how to treat trauma in the substance user. Overall, I really just enjoy kind of learning new styles and how to help clients and what is best for them. And so we're going to be looking at a good portion of that today. So the agenda of what I'm going to be looking at with you guys is first, we're going to be defining what trauma-informed care is through addressing re-traumatization, what are some common modalities and to treat trauma, considerations for treatment, especially in the substance use population. And then we'll be taking a look at treatment planning. How do we prioritize the presenting problems that clients come in with, post-traumatic growth, and then as well as some resources. So the first thing we're going to look at is SAMHSA's definition of trauma-informed care. This is not, I understand it's probably not a lot of new information from people, but because we've all probably been in some trauma-informed care trainings. And so what we want to look at today is specifically how it relates to the substance user in particular. So just kind of hang in if you have questions, and there's some things I'd like to kind of hear from you guys on too. So we'll just kind of work together through this presentation. SAMHSA has 4 assumptions and 6 principles that we're going to be looking at. The 4 assumptions we're going to start with is, and the first one is realization. So to create an environment where you have trauma-informed care, the important thing is obviously realization about trauma. And not just about how trauma affects the individual, but how trauma affects families and communities and organizations and therapists, and across the board, kind of having this broader approach of understanding and realizing the impact and the grip that trauma has, and not in the individual, but in all of their areas of life, as well as those of us that treat those that have experienced trauma as well. A big portion of realization is understanding the coping strategies that clients come in with, and so that we can kind of see and better understand the functionality of what's going on, and better understanding these things that they're doing and the ways that they're behaving and how they're managing their lives, the emotions that we see, and then better understanding that from the lens of trauma, and that these are coping strategies that have been used for very adverse experiences and for overwhelming circumstances. We can have a little more empathy when we understand what we're seeing is rooted in something that's probably much deeper and goes much more in depth than we can just see based off of what we're experiencing. I know in residential treatment, it gets very overwhelming because you have a flood of clients and then you have a flood of behaviors. And then in the substance use world, that's compartmentalized or compounded even further. And so I like to give this analogy. I give it to my clients a lot. I give it to the clinicians I work with. And I just think it's a better way of understanding the scope of what we see and understanding it more from the perspective that's a realization of trauma and how they're managing things rather than bad behavior. So this analogy is the log analogy, and it goes like this. Imagine that you're on the bank of a raging river. Something happens, you fall into stream. You fall into the river. This is not one of those like kind of calm rivers where it's just a little lappy. This is the raging river. Imagine, you know, where you're whitewater rafting. You are going down this stream. You're likely going to drown if something doesn't change. By chance, you look to your left or to your right, and you see that there's a massive log. You hold onto that log and you hold onto it with all your might, and you just get swept downstream. Once you're downstream and you're in calmer waters, family, friends, people that love you and care about you are on the bank of the river saying, "Oh my gosh, I can't believe you survived that. That's incredible. All right, swim to shore. We'll get you dried off. We'll get you help that you need." And so you, with one hand on the log and one hand swimming, try to swim to shore, but you're unable to do so because you're hanging onto this log. And I think that's the perfect analogy of these unhelpful coping strategies that people have been through trauma, as well as our substance users experience. This log was their survival mechanism. This is how they dealt and survived with the things that they went through and what they experienced. Sometimes that log is using drugs and alcohol. Sometimes that log is unhelpful coping strategies. Sometimes that log is distancing themselves from others, shoving people away, isolating. Sometimes that log is dissociating. What we want to do in the treatment setting is help them understand, we know why you're holding on to this log. It's causing all these behaviors that aren't helpful for you. It's not helpful for others, but we understand why you're doing that. This thing that literally helped you survive is now actually harming you. It helped you survive your trauma. It helped you survive your substance use. But now that you're sober, now that you're seeking help for the things that you've experienced, it's now harming you instead of helping you. So our goal as clinicians and people that treat these clients in this population, is to give them the tools and the strength to slowly distance themselves away from that log and actually be able to swim to shore. It's impossible and honestly an unfair expectation to tell them they should just be able to get rid of the log and swim to shore. And so I like to use that analogy because it provides a level of empathy, but also helps us understand what we're actually trying to do here. We understand what they're going through, that they can't sustain and continue to hold on to that log. They're just going to drown or starve themselves in the river, just hanging on there. We want to give them the skills and the ability to like actually distance themselves from that log and then swim to shore. So for me, a big part of realization, that's what we've got to do as an organization. That's what you guys that are treating clients in a private practice setting, or if you work with a substance use population, realize the impact that trauma has and what they're doing is a function of their survival rather than what they're doing is bad behavior. That's huge in the substance use population, by the way. It's not that you're bad, it's that you're struggling with this thing, and people really need to know that you care and that there's a path forward for them. The second assumption from SAMHSA is recognition. And this is really the ability to recognize and understand the signs of trauma. And the best way we know how to do that is through appropriate assessment. We'll get into that a little bit later, as well as appropriate screenings. We'll get into that later as well. Prevention is a big one. There's lots of great organizations and communities that focus on prevention of substance use, as well as prevention of trauma. A lot of good guidance counselors are doing great things in schools for prevention of these things. And that's one of the better ways to recognize is to be able to engage in all of these things. Obviously, treatment and recovery are also ways that we recognize the signs of trauma is through these types of modalities. The third assumption is response. And this is essentially how we apply the 6 principles of SAMHSA's principles that we're going to look at in the next slide, but how we incorporate them and how we apply them. The first one that we kind of look at is, well, how do we inform and help everyone that's involved in your organization better understand trauma? That comes from the person that's greeting the client at the door. That comes from the nurse down in the detox unit. That goes to the clinician that's working closely with the client. That's also through the person that might be discharge planning or the UR person that's getting them extra days through their insurance company. If everyone kind of knows and understands trauma-informed care, we're able to provide a more broad range of help for these clients that are struggling with trauma. So it is across the board. Can everybody be informed in the organization, the people that you're working with, about what's going on and how to help these clients? The next way that we kind of look at a good response level and how to apply these 6 principles is through training. Having appropriate training, whether that be supervision, whether it's CEU trainings like this, whether it is just basic trainings within your clinical organization. Also, a big part of that is making sure your budget within your company allows for trainings so that everybody can be informed to be able to provide the appropriate care necessary. Um, and then just effective leadership, I think, is one of the best ways that you can have training that everybody knows how to help this population. That comes from the top down. If you've got leadership that understand we're dealing with this population, people need to be informed so they don't cause more harm. If the leadership knows that, it trickles down to the rest of those in the company or in the practice, whatever setting you're working in. Another way of having response and applying these 6 principles is through policy, through your mission statement as an organization, through the things that you put in your handbook, through the policy that you implement on a day-to-day basis that helps you make decisions and treat clients. I think that's an important part of how we respond is that it's in all appropriate settings. That way, when you're talking with your clinicians, we're going over policy. This is how we treat clients across the board. And in the handbook and in your mission statement, everybody kind of knows that when they come to you, that you're going to be informed of trauma and know how to help the individual. And then, kind of the last thing I would say in the response is making sure that there's a commitment. We're not just saying words, right? We're not just saying, oh, well, it's in our mission statement and we do some trainings, but we actually apply these things and we're actually committed to applying these principles to be able to meet the needs of those that we're servicing. It's one thing to have lip service and say that we do these things. It's a whole different thing to be able to practice it on a day-to-day basis. And honestly, practice it when it's hard, not when it's easy. It's easy to apply it when we're just kind of like talking about it, or you've got a client in front of you where it's very clear there's a trauma situation going on. In the substance use world, that is harder to practice when we're seeing bad behavior, when we're seeing the resistant client, when we're seeing all of these things that are kind of harder to treat. It's even harder to maintain this informed level of care because of what you're dealing with in front of you. But it's more important to practice it when it's challenging than when it's easy. The fourth assumption, and we'll get into much more of this in a later slide, is resisting re-traumatization. That is very easy to do in those that have experienced trauma, just because, especially if it's unprocessed trauma, there's triggers across the board. There's all kinds of things that they've experienced and that are going on. And it's easy if you're not mindful to accidentally or inadvertently re-traumatize a client. I don't think any therapist sets out to re-traumatize a client, but it can happen if we're not mindful. One of the ways I watch that happen most is when places are inadvertently having chaotic or toxic work environments. Clients can pick up on that stuff. In our substance abuse world, we can only control so much of that because we have a population that's coming in that they're newly sober, they're just getting on the right meds, they're detoxing, they're around other people that are also newly recovered on medicine, detoxing. There's only so much within the population that you can manage to create as little chaos as possible. And there are certainly ways to do that. I think it's more important and more prevalent more important in primary that within your organization, whether it's with your clinicians or whether it's within your leadership style, that you're creating as least of a chaotic environment as possible. That looks like we're focused on good client care. That looks like we're meeting clients with empathy rather than frustration. That looks like whatever conflict we have with one another, clients don't see that, or whatever issues are going on, clients should know anything about that, or any frustrations we have, we deal with them on our own. So that we don't take those things to group or we don't take those things in our individual sessions. And so to avoid re-traumatization, we're going to look at how we avoid that in the client. But I think it's important that we talk about how we avoid that within an organization as well. And the best way I know how to do that is clear communication. Everybody has their roles. Everybody has this mindset of we're working together. That is the best way I know how to create the most effective environment that doesn't set the client up to be re-traumatized by something chaotic or toxic. So that moves us on to SAMHSA's 6 principles of trauma-informed care. We're going to look at this a little bit more specifically when we look at a substance user, but for now, we're just kind of laying out the principles. The first principle is safety, and the purpose of that is a client really cannot get into any kind of trauma work if it's not a safe environment. The purpose is to create an environment where a client feels not just physically safe, but also emotionally and psychologically safe as well. That means they understand what you're sharing with them is staying in that room to the extent that it's appropriate. For example, if they share they're going to hurt themselves or someone else or anything of that nature, we have that duty to warn. But outside of that, they know and understand that their information is safe. It's going to be met with non-judgment, and it's going to be met with empathy, but also a desire to help them grow and move through the things that they're experiencing. And, when you create psychological safety, it is about how it's client focused and how you're helping them specifically. So safety is an important principle in trauma-informed care. The second principle is trustworthy and transparent. Trustworthiness, the goal is to obviously build the rapport with the client. That's the best way I know how to build trustworthiness in a client to therapy relationship. I will say, what comes with working within the trauma client as well as in the substance use population is there has to be a certain amount of direct communication and confrontation at times. And how do we move through what you're experiencing? That is really hard to do if you haven't done the work on the front end to build that therapeutic alliance. And if you haven't developed that rapport with a client. A little self-disclosure here. When I was a new counselor, I was working a night group and it was primarily men. And so it was really important to me that group norms were established and that we were all working together. And I had a client who, I don't even remember what the situation that was going on, but I confronted that client and it was the right thing to do, but I had not developed the rapport with that client yet. As you can imagine, that went south very fast. It did not go well. And the reason it didn't go well is that that person didn't know me and that person didn't trust me. And I was not able to really have that level of honesty because that trust hadn't been developed. They don't know me from Adam. Who am I to come in and share this information with them or confront them on their behaviors? I think it's important when we're looking at principles of treating the substance user as well as a person that's experienced trauma, do the heavy work on the front end to build the rapport. If they know that you're there for them and you're going to be honest with them, but you're also going to be empathetic with them, and your main goal is to help them and to help them become more functional in their lives, they will see that. They will see the authenticity. They know that that's what you're about. And so my biggest suggestion in applying this principle specifically is do all of that heavy lifting on the front end. It will benefit you on the longs on the other side of it, because then you will be able to say the honest thing and to be able to confront them and to be able to help them be truthful with them about what is necessary and needed to move forward. That's just really hard to do until you do the rapport. So, and then transparency. Again, I tell clients a lot. I'm like, hey, my job is I owe you my honesty and I owe you transparency about what we're doing, what our practices are, what this modality is, how beneficial or effective it is, how I learned about it, how I've been trained in it. Them knowing and understanding the process is a really important part that actually helps them feel more stable and secure in what they're doing. So trustworthy and transparent. The third principle from trauma-informed care is peer support. When we're specifically looking at those that have experienced trauma, peer support is massive because trauma, when you've gone through something really challenging and really hard, and especially if it's a trauma that you personally individually experienced and it wasn't like you were in a car wreck with other people, there is a sense of isolation. There is a sense of I've gone through something nobody else understands, especially if it's some kind of trauma that happened as a child to you. There's typically what comes with that, this verbiage of you can't tell anyone, people are not going to love you anymore. I've heard that often when I've worked with trauma individuals, especially women that have experienced, women and men that have experienced childhood abuse trauma. There's some kind of element of not being able to share this information with others. And so putting the trauma individual into a group setting helps them see and understand, oh, I'm not alone. I'm not the only one that's had that experience. And it opens up their world entirely. So going from I'm isolated, I can't tell anybody what's happened. This is a thing that has shifted my whole worldview around. Now you're getting around other people that can say, I understand exactly what you're going through. I've been through that very thing as well. That peer support is massive. When we look at treating children that have experienced trauma, that peer support looks a little bit different. And that comes more in the form of safe caretakers that were non-offending people. So that might be a parent that's not the offender. That may be family members, some kind of care advocate, and we'll look into more of a specific modality that's child focused. But the peer support for a child is going to come more in the form of caretakers and guardians and parents and safe adults that were the non-offending party. And that's important. A huge portion of working with children that experience trauma is involving safe caregivers. But we'll get into that later. The fourth principle is collaboration and mutuality. This one is on there, and the purpose of it is to level the playing field. And what that means is you've experienced some trauma and some things that have gone on in your life, and we're here to collaborate together. Because people that have gone through trauma have experienced a massive power differential. Power's been taken from them more times than not, whether that is relational trauma they've experienced, whether that's a sexual or physical trauma, even if it's an experiential trauma like a house fire or a tornado or a robbing, something like that, some kind of experience rather than something happened to you personally, still power's been taken from you. And so when you move into the treatment phase and you're working with a client that's experienced trauma, it's important for them to feel a part of what's going on rather than I'm the expert here and you're the client down here and we're going to do what I say to do. I don't think anybody sets out to do that. But unless you're kind of mindful of we're creating a partnership here, that's easy to happen. So that collaboration to where the client really feels like they're a part of the process is very important. The fifth one is empowerment, voice. What I also didn't put on here is empowerment, voice, and choice. Like we just said, those that have experienced trauma have been disempowered, either by their experience or by their abuser. And so it becomes massively important in this trauma treatment that we're working on is how do we help a client feel more empowered? How do we help them find and utilize their voice? How do we help them know and understand that they actually have choice now when something happened that maybe they didn't choose to happen? And so reinforcing and applying that principle across the board is vitally important because you're trying to teach clients that have been through trauma to be resilient and to go from being a victim of something to being more in charge of their lives and to not feel so victimized by all the things that have happened and instead to feel like they are able to move forward, that this thing that happened doesn't define them. And so we're really working in the treatment setting on empowerment rather than constantly feeling disempowered. And I will also say, sometimes when people have experienced trauma, what you see very easily is that they try to regain control of the narrative. I most have seen this in sexual traumas where someone was sexually traumatized as a child or as an adolescent, and then you see in adulthood where perhaps there's hypersexual activity. And what we see in that is they're trying to regain control of the narrative. They were disempowered. And so they keep trying to get empowered again by choosing, well, I'm the one making this choice and I'm doing all these things. But in fact, the continued behavior continues to disempower them. So through the treatment process, we also help them understand the things that they're doing to try to deal with the trauma are actually disempowering them, not empowering them. When you don't want to look at it and put it away in a compartment, it just has control over you rather than you being in charge of how you're dealing with it. So a huge core principle there is focusing on empowerment, focusing on resiliency. The sixth principle that we look at is cultural, historical, and gender issues. This is an important part because somebody's culture absolutely paints the picture of how they're going to handle something, absolutely paints the picture for their lived experiences, how they've been taught to deal with things. That's a massively important thing to remember and consider. Their historical background, the things that they've been through, their history, the things that they've gone through, understanding and letting these things be a part of it is it's important because that paints the picture for who they are, how they're going to deal with things, any barriers we have to overcome, and how they're going to use these coping tools and move through this trauma. It's important to understand all these things. And with gender issues, we want to make sure that we're moving beyond biases and we're moving beyond stereotypes across these three things here and really focusing on the client as an individual. That may come down to what are their preferred pronouns. That may come down to how do they like to be referred. That may come down to what's been their experience. We don't want any kind of gender issues to be a detriment and keep them from getting the help that they need. And so the role as the facility and as the clinician is to be aware and to be mindful that these are massive, and these are things that actually paint the picture of who they are as a person, and it helps them move forward. So now we move on to addressing re-traumatization potential. What I will say, we're going to be looking at understanding triggers and then knowing signs and symptoms. Understanding triggers, some common triggers are anniversaries of an event, anniversary of a death, anniversary of something that happened. That's a huge one. That's a massive trigger for a lot of people. Events similar to the trauma event they experience. If you had someone that was in a car accident on a rainy night, guaranteed if they've not done any work on a rainy night when they're driving down the road, they're probably going to be a little triggered. And so understanding that these things happen, it's not within their control. They're not trying to make these things happen, but it is a part of when you've experienced trauma, it's likely to be re-triggered. And I try to explain to clients that when you go through a trauma, what happened, including the event itself, the sights, the sounds, the smells, the time of day, the time of year, what somebody was wearing, who it was, all of that just kind of gets locked into place, and it's like it gets stored in your brain until you can process it properly later. And so knowing all of that, and that's kind of trapped up there, we can see where triggers might be a little landmine. We never quite know when we're going to step on one. And so to avoid re-traumatization, we understand that triggers are a potential. I will say this, in working with the substance user, the thing we have to be careful of is this is also a population that a survival mechanism as part of their disease is manipulation. I've worked in many settings and within the treatment where somebody may say, well, I'm triggered, so I don't want to go to group. Well, that person triggers me, so I don't want to talk to them. That medication triggers me, so I don't want to take it. And so that's we understand that triggers happen, but we also maintain a mindfulness to say, okay, we don't want to just throw around the word trigger either if it's not 100% accurate to what's going on. The best way to address that, to me, is to sit down with the client one-on-one when they say, hey, that triggers me, so I don't want to do X, Y, and Z. Sit down with the client and say, hey, what's going on? Tell me about that trigger and what's happened. That usually opens up the world where you can kind of see, is it being used as a way to not do something? Is it a true trigger that we need the coping tools? Because whatever function it's serving, we need the appropriate solution for it. If it is a trigger that happened and it's absolutely triggering their trauma, then we need to find helpful and effective coping strategies. If it is, they just don't want to deal with it, or it's too overwhelming, or anything like that, then we want to help them and push them and challenge them to say, hey, based off of your trauma, what has happened is that your world's become very small. We went from our threshold to being able to deal with life like this, and we experienced trauma, it moved to like this. And then everything we feel like we can't do because it might trigger our trauma, we just get smaller and smaller and smaller and smaller, and our world becomes impossibly small. And the whole point of trauma treatment is we want to broaden your world out to where your whole life is not a bunch of I can'ts. And so the main reason why we look at that, as we say, is it a manipulative tactic? Is it something that's actually happening? Is it something to work through to help you feel more capable and empowered to maybe, can I sit through that rather than immediately telling myself I can't? Can I maybe lean into that conversation rather than leaning out of it if it's appropriate? The best way to know that is to have the conversation then. A part of understanding triggers is being aware of some risk factors that exist. These are risk factors of re-traumatization. Substance use. If you are in a private practice or you're working with children who live in a home where maybe substance abuse is occurring, it's going to be really easy for re-traumatization to happen if you are not actively sober or you're not in an environment that is sober. So that's something to pay attention to. Like I said, if you're in a private setting and you're working with a client individually and they're misusing substances or in active addiction, it's going to be really hard to do that work. And they're going to keep, especially in the substance user, there's a high risk if they're not sober and in recovery that they're going to keep re-traumatizing themselves and keep getting into situations that cause more trauma, compounding the trauma they already have. So substance abuse is a massive risk factor here. Early recovery is a risk factor for re-traumatization. In early recovery, what we see is, people are coming in and they're detoxing. They are not their best selves. Emotions are all over the place. Physical sensations are all over the place. And so early recovery is just, you're like a little nerve that has no wraparound. It's like an exposed nerve ending, just kind of walking around. Everything feels like it's overwhelming. And so the risk of re-traumatization when you are fresh, 0 days sober, 3 months sober, even 6 months sober, that early recovery is a real prime risk factor to be re-traumatized if not careful. Another risk factor to be aware of is unsafe situations, especially our younger population. It's really hard to do trauma work with kids or with adolescents if they're returning to a home that's unsafe. And so being able to assess, and it may not even be physically unsafe, but it may be emotionally unsafe, being able to assess and know and understand that that might be prime for re-traumatizing if they're in an environment where they're not actually safe. Unhelpful coping strategies, going back to that log analogy, being a risk factor is their unhelpful coping strategies. How they've dealt with the trauma is they may have our brain's most organic way is to kind of shut the system down, kind of numb it all out, maybe even dissociate so we don't have to experience the full weight of this trauma and what's going on. What we look at when you start to get sober or when you start healing this trauma is to understand, and maybe it's not even unhealthy as much as it's unhelpful. I like to do that with clients sometimes to say, hey, the things that you're doing, for example, whenever you isolate, that's either helpful or unhelpful. Sometimes you're an introvert, you need to recharge, it's helpful. If you are putting everyone away and not looking at anything and not willing to go anywhere, now it's unhelpful. And so sometimes that's a better workaround for clients to be like, instead of what you're doing is unhealthy, it's unhelpful to you. It's not working, it's causing more problems than it's helping. Another risk factor is lack of economic and social supports. It's really hard to be able to do trauma work when you don't have the financial resources to do it. It's really hard to be able to do the things you want to do or to stay in treatment when you don't know where your next meal is coming from. We're going to get into that in a little bit of prioritizing of needs. And another one, and also lack of economic and social supports. It's challenging in a risk factor of re-traumatization is if you've got people in your life that don't understand what you went through or create a message of what you went through wasn't that bad, or they don't understand why that would be so hard for you. And so really it's the clinicians understanding that if they're in an environment like that and they have messages like that thrown at them regularly, they're in a prime place of being re-traumatized. And then being emotionally disconnected, not paying attention to, not having mindfulness and not being connected to any part of your emotional world absolutely puts you at risk of being re-traumatized. A big part of what we do in short-term treatment settings is, can we get you to the place of emotions one-on-one? Can you identify an emotion? Can you feel it appropriately? And then can you use effective coping strategies to manage it? Because especially in the treatment center world of substance use, their emotions are just coming back online. They've not dealt with this stuff in a really long time. And so stabilization in those things and learning how can I even contact my emotional world is a big part of the puzzle, and disconnection from it just puts you at risk of experiencing re-traumatization from something you've experienced before. Knowing the signs and the symptoms, thoughts, behaviors, emotions, physical appearances, our job is to kind of watch out and observe what we're seeing. You'll know by how someone's talking where their head might be. You're seeing by the things that they're doing around you, what their behaviors are looking like. If you're in a setting where you have the access to the family system, you can get reports from others about how they're showing up or what they're seeing. And physical appearance is a big one too. If someone's coming in, they're kind of disheveled, they look very tired, lethargic, maybe kind of flat or blunted affect. That's something to pay attention to. Could be some other mental health like depression, but also that they may be, especially if they're engaging in trauma work, they may be having a hard time with it. So paying attention to that. The main goal here is to manage and develop resiliency with those that have experienced trauma events. That's the whole purpose. In shorter term treatment settings, helping the client develop a foundation, like I said, is the most important thing we can do. We have clients that come in that have experienced trauma. They're very eager to get the trauma work done. They've been to treatment before. They've heard that you got to address your trauma in order to move forward. It might be contributing to your substance use, and all of that very well may be true. However, they have no business doing trauma work if they are not stabilized physically, first of all, and then if they don't have some kind of core foundation of coping skills, because we all, anybody's done trauma work, you know, it is destabilizing before it's ever stabilizing. And so in these short-term settings, you may be working in a short-term setting, and you want to get to the trauma work and we want to do all the work with the clients. But the truth is, going back to the basics and kind of getting them a functional foundation is one of the best things you can do to help them treat trauma down the road. In these short-term settings, hey, can we help you understand what you're feeling, experiencing? How do we help you regulate emotionally? How can you tolerate the distress you're experiencing? How can you relax when you get overwhelmed or flooded emotionally? These are we want to skip past those and get straight to the trauma. Those building blocks are paramount. I've done a lot of EMDR work before, and it's really challenging to do it if there's not some kind of stability before they do it. So regardless of what kind of setting that you're in, if you're in a setting where someone's going to be for a while and you really get to do that trauma work, again, taking the time to build the foundation is important. If you're in a short-term treatment setting like a PHP program or inpatient, you want to get to these things, but it's actually more important to help them build that foundation that's going to set them up for success in trauma work down the road. If you're working with children, even more so helping them better understand coping tools and mechanisms, that's a massive part of trauma work. And it helps them not be re-traumatized later. I'm curious, those that have that do trauma work or anything like that, are there any specific signs or symptoms you've noticed in your population, whatever kind of setting that you're in? Are there specific signs and symptoms that you've noticed when a client might be becoming re-traumatized by something they're experiencing? We looked at some of these things. I was curious if there's anything you've experienced in your personal dissociation, shutting down, emotional dysregulation. That's a massive one. And again, kind of earlier, we were talking about, can we observe these things as a function of them surviving what they're going through? Anger, that's massive. Especially, we see that a lot in men more than women. Women tend to have a lot more emotional sadness response to things they've gone through. It's not impossible, but men get really angry. And then the whole treatment process becomes, well, how do we help them manage their anger and their aggression? In kids, the inability to manage emotions. Ooh, someone said resentment. That's a really good one, which kind of ties into anger. And then when we look at a trauma, and a person's experienced trauma and they're a substance user, the beautiful thing is we have the 12 steps where we connect them to the 12-step model, and the fourth step is where you look at resentments. And so there's a good process for that. Increased anxiety, low self-esteem, missing work. Someone made to go in an emotional dysregulation of talking louder and faster because their system's flooded. So they may not be shutting down. They may be amping up, actually. That's a good one. A seizure. I've seen that before, too. They just get so dysregulated, they have a seizure. Guarded. They don't want to talk to people. Those are great examples. I appreciate y'all sharing those with us because you guys have your experiences as much as I have mine. So I appreciate y'all sharing your thoughts and feedback as well. So one last thing I wanted to kind of address in addressing re-traumatization is, again, going back to what we talked about, is develop the rapport and the trust that will help minimize the re-traumatization. Letting clients go at their own pace while also keeping them from getting stuck. If you're in the weeds and you're actually doing the trauma work with a client, not pushing them. We know certain trauma treatment is going to be effective. We know it's going to help them. We know it's going to be beneficial to them. However, it's kind of pointless if they are not actually committed to doing it. Through the therapeutic alliance, you can talk about, well, what are the barriers? What would be the benefits? And they might come more on board and understand the need and necessity for it. And that's amazing. We don't want to push the client. We know it'll be helpful, but if we push the client too far and they don't actually have a readiness or commitment to do the work, then they're kind of worse off for the wear otherwise. And so going at their pace, once they're engaged in the work, going at their pace, but also once they're in the middle of the work, working with them to not get stuck on where they are is a big one. Addressing re-traumatization. The next thing we'll look at is common therapeutic modalities. There are tons. There are lots of really great peer-reviewed, discussed, lots of resources and things like that out there. We're going to be looking at 4 today. We could spend the whole day talking about every kind of therapeutic modality out there. So we're going to focus on cognitive processing therapy. We're going to focus on EMDR, trauma-focused cognitive behavioral therapy, and then what does it look like and what are best practices doing trauma work individually as well as in a group setting. So the first thing we're going to look at is cognitive processing therapy. CPT is a type of cognitive behavioral therapy, and it's specifically focused to treat trauma. It's a structured modality. It requires training. You can find worksheets and things like that online and pull some resources, but by and large, there's a model for it that does require training. You can pay for that. You can look at that online about how to get trained in that kind of processing. But by and large, it just kind of utilizes different exercise. Clients have homework, and the whole goal is to process their experience more effectively and have more adaptive ways to think about their trauma. So some goals of CPT are understanding PTSD. A lot of people get the diagnosis and the label, but they're never actually gone through, well, what are the criteria? What are the symptoms? What are you experiencing? What does that mean for you personally? How are you experiencing it? Because there's a lot of people where, you look at the DSM criteria for post-traumatic stress disorder and the rule outs and all that kind of stuff with it. But then you have a lot of people that experience symptoms that are related to PTSD that wouldn't necessarily be mentioned in the DSM criteria. So helping them understand how they're specifically experiencing these symptoms and what they are. Like some people may say, well, sometimes I just kind of go to a different place, and helping them understand, well, that's a flashback. Sometimes they don't have the words for it. And so education is empowerment at the end of the day, helping them understand what that diagnosis is. So CPT does a lot of understanding what is PTSD. A big component of CPT is acceptance of reality, because we can't change what we can't accept. You can't change what happened, but at the same time, we can't change or get out of our stuck points until we can acknowledge what's happened and we can actually accept the reality of it. A thing that happens whenever you've experienced a trauma is, I don't want to go there. I don't want to think about it. We just kind of compartmentalize it or put it away. And so a huge thing is, can we actually come to the table with CPT? Can we come to the table and can we help you understand what did happen, and then also help you accept that this is the reality? You see acceptance of reality in all kinds of treatment modalities. It's a big component of dialectical behavioral therapy. It's a massive component of acceptance and commitment therapy, because we know clients can't move anywhere else beyond where they are until they can accept that that is in fact where they are. And this is the reality of where they are. So it's a huge component in lots of different types of therapy, but specifically in treating trauma, we can't get to the pieces that actually work for us if we can't accept that this is what's going on. Feeling emotions is a big part. Again, we talked about that earlier, of most people just don't want to feel bad. And that's understandable. I don't like to feel bad either. However, when we're dealing with trauma, if we ever want to move beyond our world being this small and feeling incapable and feeling disempowered, we got to pull the world out. And that includes, we got to feel the stuff. However, and then establishing some problem solving skills is a big component of CPT as well. Because we don't want to get to where it's like, well, you need to accept the reality and just feel the emotions and that's it. People need to feel there's some kind of solution. I'm doing something actively. I'm moving through this. There's some kind of purpose, some kind of meaning behind what I'm doing. And so CPT focuses on, great, how can we establish some problem solving skills? How can we help you maybe move toward a more adaptive thinking pattern, which is the next one, adapt negative thinking habits. Because often what happens when you've gone through something traumatic is it's shifted your whole world. What I think about myself, what I think about others, what I think about the world in general around me changes whenever you've gone through something traumatic. How could it not? Suddenly I was living in a world that felt relatively safe. Then this thing happens and now it's shaking that and I no longer feel safe. And so what comes with that tend to be some negative thinking patterns, whether it is nothing is safe, or this was my fault, or I could have done something differently. We see those negative core cognitions that show up when you experience trauma. CPT is kind of a model that focuses on how can we find a more adaptive way of looking at this and get back to a daily routine. That's the biggest portion of that. We want you to get back to life. As far as CPT goes, a big thing is that the clinician comes on board and helps the client really determine these things for themselves. So this works best with a population that can kind of hang with that kind of processing. So rather than a clinician coming in saying, well, this is what it is and here's what you do, they kind of open it up a little bit and say, well, what do you think is the function of that? Here's what some people think about that. And it's up to the client to decide whether or not they want to adapt a different perspective. Because one thing we know is you're more likely to hang on to something if it's meaningful and purposeful to you rather than it's something that's just told to you. So the client's led through this whole process through writing exercises, through exposure to the things around them, to the traumatizing events, through all of these things, and getting to the place where they can feel the emotions and process the things that have happened. They get to a place of where they can actually say, you know what, maybe a more adaptive way of thinking about this is it's not my fault, and instead it is a thing that happened, rather than, well, it means that I'm bad or I could have done something differently. A more adaptive way of thinking about it, CPT teaches that. So the next thing we're going to look at is just a brief video that shows an explanation of what CPT is. I'll pull this up.
The main way in which CPT works is to look at the way people have made sense of the traumatic event. And there are some ways in which you've made sense of it that can keep you stuck in the trauma memories, and they keep occurring because you haven't really developed a story that you can live with. And that's the main way in which CPT works. And so in the spirit of figuring out the way that you made sense of it, early on there's a focus on the therapist asking more questions, hearing about the event, either by virtue of the patient writing a trauma account or the therapist asking curious questions about what happened. And early on, that's the therapist's job more. And then as the therapy progresses, there are sessions that are really designed to teach the client how to become their own therapist so that they can use the skills to continue to unravel those stuck points or ways of thinking that have led to them not recovering from the traumatic event, and then to be able to apply that in their day-to-day life.
The therapist's job is not to instill our beliefs on the client. So what I more think is a better way to look at that process.
I'm hearing from the chat that it's audio only, and something's happening where I'm not able to share this video. So we'll just go with audio only. I'm sorry about that. And if it is in the slide presentation, if you would like the specific link to it where you can watch the video and not just listen to the audio, I will see about pulling that link and then adding it into our chat so you can watch it and not just listen to it.
Yes. Is the client almost going to like a court of thought in a way, where they have a prosecutor and they have a defense in their own head? And you're looking at evidence, and in your own head, you're learning to look at it from multiple ways. So you take the same evidence, you write it down. They do a lot of detailed journaling. They actually write a trauma story. They write a trauma impact. And in doing those accounts, and they go back and they look at it from multiple viewpoints. The prosecutor's telling you, you're right, the world's bad, the world's dangerous, you should leave that. The defense attorney saying, wait a minute, you forgot these nice people over here and that person at the store who helped you out when your baby was sick. And, and so that evidence back and forth starts to get you to have a more balanced view.
Yeah, so that's just a brief explanation of CPT, just in its basicness of how it works and how it operates. Sorry, let me get out of this.
PE is a treatment that helps people.
Give me just a moment. Sorry. Cue music. There we go. Okay. All right, so this is an example of a worksheet, a cognitive processing therapy worksheet. It is very blurry. I'm not sure what happened. I apologize for that. Again, I'll try to find the link for this and put it in the chat before we leave. But this is an ABC worksheet that's often used in cognitive processing therapy that clients take home with them and often work on it at home. And it's just understanding whenever something happens and you get activated, it's ABC, identifying the activating event. So something happened. What was that something? The B is the belief and the stuck point. Well, I'm telling myself something about what happened. And then the consequence is I feel something based off of my thought, based off of telling myself something and what happened. And so it helps us better help the clients understand, well, what's going on here, and really kind of slowing the system down, because these negative thoughts, especially in the B section, tend to be automatic, especially if you've gone through trauma and it's been a while before you get to therapy and start gaining different skills. These belief points may be something you've been telling yourself for decades. They don't come unraveled that easily, but if we put some mindfulness to it, and then we start using these different tools to help kind of challenge the thought and have a more adaptive thought, that's the purpose of this. The questions at the bottom, it says this is an example of how you would utilize this sheet. So you identify those 3 points and then ask the question, are my thoughts above in B realistic? So it may be, well, I did something wrong, or I did something bad, or I'm at fault, or I'm to blame. And then we can even pull in some kind of behavioral techniques, such as challenging negative thinking. Is this something that what supports this evidence? What contradicts this evidence? Is this something I've gotten used to saying, or is it something that's realistic and true? What would I tell a friend about this? And then you kind of start chipping away at, this is something I've just told myself over time that actually isn't realistic. It's the way I've put it. It's maladaptive thought process. And so we're trying to make it a little more adaptive. So we say, is it realistic? And then that second question says, what can you tell yourself on such occasion in the future? So you're likely going to return to this stuck point. This belief doesn't go away overnight. And so the next question to ask yourself is, well, what can I tell myself once I've determined it's unrealistic and it's a thing I've gotten used to telling myself and it's an unhelpful, maladaptive process? What's something I could tell myself in the future if this occasion occurs again? And then you identify what those things are, so the client has this kind of this formula they can use in the future. So that's just some examples of CPT. So we're going to move on to the next one. Goodness. Which is EMDR, eye movement desensitization reprocessing. EMDR is structured where the patient is able to focus on the trauma memory while simultaneously experiencing bilateral stimulation. Bilateral stimulation is just left to right brain. That usually happens through eye movements, where the therapist is in front of the client moving their fingers, and they say, follow my fingers with your eyes, while they're focusing on the trauma event. That may happen. Some people have tappers. Some people have headphones. You can elicit bilateral stimulation in several different ways. And the purpose of this is when we engage in bilateral stimulation, it's our brain's most organic way of processing. When you're asleep at night, how many of you experience wild, vivid, crazy dreams? It's a dinosaur. It's what you had for dinner. It's what your husband told you before you went to bed. It's some experience you had with a fourth grader that told you were ugly. Like, all these things just kind of come up out of nowhere in this weird, wild, vivid dream. And the reason that's happening is because you got in REM sleep, which is rapid eye movement. You don't realize that, but at night your eyes are moving like this, and it just means that your brain is processing back and forth. And so we take that process in EMDR and put it while you're awake, and we identify the trauma event and use that bilateral stimulation to help your brain process what it's been through. And so in doing that, we desensitize what happened so it doesn't feel as bad. And in fact, when you start, you take a rating on a scale of 1 to 10. How intense or dysregulated does this emotion feel? And then by the end of it all, we want to get to as low as possible. We want to get to 0. Sometimes that's unavailable just based off of the trauma itself, but the goal is to get it as low as possible. And so we're desensitizing what your feelings about what happened, as well as reprocessing. Part of reprocessing is getting different cognition, seeing things in a different way. You might remember something else to the event that you hadn't thought about before. And basically, we're taking that trauma memory where it got stored up there after it happened and dragging it all down and giving it all a proper home is the best way I know how to describe it. A part of that reprocessing, too, is where you identify a more adaptive, positive cognition that replaces the negative one, kind of like CPT. So EMDR has 8 phases. There's the history and treatment planning phase. In that one, we're identifying, well, what do we want to work on? What all has happened? And we kind of narrow down, like, can we get to a touchstone memory or the first memory or the most impactful memory? And we kind of identify where we're going to start. The second phase is preparation. We're developing the therapeutic alliance, we're explaining the process, we're setting expectations, we're developing effective coping strategies. EMDR has a protocol of creating a calm place through using bilateral stimulation that is, it's amazing, it's effective, it works really well, and it helps them kind of stabilize once we're done with the work and we need to kind of contain it and put it away until we get to it next. The assessment phase is where we're identifying, well, what exactly are we processing? What are the images associated with that? What are your thoughts about it? What are your beliefs about it? What are your feelings? What are your sensations? We're identifying all the things associated with it. And then we engage in the bilateral stimulation that desensitizes and reprocesses, which is step 4. Step 5 is installation. At the end of it all, once it's been reprocessed and we have as low of a rating as possible under stress, then we identify, well, what do you want to believe about yourself? What feels more true to you now after we've processed this properly? And then we use the bilateral stimulation to do that. Then we do a body scan to make sure their body agrees. Sometimes we do all that good work and then something kind of still feels off, and then probably something just didn't get fully processed. We go back and do it again if necessary. And then 7 is closure, returning to a state of calm, whether the reprocessing is complete or not. More times than not, there's multiple, in fact, most times there is multiple EMDR sessions. You don't get to it all in one session. So then you close, there's container exercises for that, calming techniques, and then you pull it back up and keep doing it until you're at the end. And then phase 8 is reevaluation to determine how effective it is. What do we want to move on to next? So I'm going to show a video. I'm not going to show it. You're probably going to listen to it if history repeats itself here. There we go. Again, I will link this if the video does not automatically pop up, which it looks like it's probably not going to. I should have some music that plays while this loads. Okay.
If you have post-traumatic stress disorder or PTSD, all kinds of things in everyday life can trigger a traumatic memory and create stress. Specific places, loud noises, large crowds, even everyday things at your home. The thoughts, feelings, and physical sensations you had during your trauma can affect how you feel, act, and think today. Reduce the stress caused by these memories. One form of talk therapy that has proven effective for treating PTSD is eye movement desensitization and reprocessing, or EMDR. Memories can be made up of many images and related feelings, and EMDR helps you reprocess the trauma to experience it in a different way. EMDR starts with history taking. This involves describing important life events and the trauma you want to work on, as well as your treatment goals. You'll learn ways to manage your anxiety too. Your therapist will ask you to look back at the trauma and think, what negative thought about yourself do you have from that experience? What would you like to believe about yourself going forward? How bad does it feel to you right now? You'll start processing a memory from there. Your therapist will have you move your eyes back and forth while you think about the trauma and those related feelings. This phase, new and useful information comes up, and old, painful thoughts, memories, and feelings fade and become less distressing. The end of processing, you'll look back at the positive beliefs that you want to have about yourself. Processing is over when these positive beliefs feel true to you and there are no unpleasant sensations in your body. This phase of treatment may take several sessions, You may also work through more than one traumatic memory before treatment is over. EMDR doesn't require you to take medication. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who've completed EMDR show noticeable improvement in their symptoms, and many no longer have PTSD. EMDR works well for both men and women, and it's evidence-based, which means EMDR has been proven to work in multiple research studies. If EMDR sounds like it could be right for you, talk to your doctor about finding an EMDR provider.
That's just a brief explanation. I've attached the link for the EMDR video in the chat. I will, once I get done and Zach comes back on, I'll get the link from the CPT one and add it to the chat as well. Again, sorry about the video. Okay, so we are going to, oh gosh, sorry. Next, we're going to be looking at trauma-focused cognitive behavioral therapy. This one is more focused is specifically focused on addressing the needs of children and adolescents and families suffering from the effects of trauma. That can be sexual abuse, physical abuse, violence, all of these things. This modality brings in the non-offending parent, like we talked about earlier, and they're a big part of the process. The core features of this are focused on psychoeducation, especially with children, having the verbiage and appropriate verbiage to understand what's happened, what's going on, why they're feeling the way that they feel, as well as provide that education to the non-offending family members and helping them better understand what they're personally experiencing, how they can best help the child that's going through the thing that they've experienced. The second core feature of this is coping skills. That is developing relaxation techniques. How can they learn to identify and process to the point that it's appropriate with a child, especially they don't have as many of the cognitive capabilities as adults do, but to their level, being able to gain the coping tools to process what's happened. Gradual exposure, sorry, I skipped down to 4, cognitive processing. The gradual exposure, that's kind of done in 2 different ways. One of those ways is kind of done in exposing them to talking about what happened, and then more in vivo exposure of exposing them slowly back to their environments, especially if they can't escape maybe an environment where trauma occurred, helping them feel more comfortable, more capable within those settings so that they're less activated, less overwhelmed, and that kind of stuff. And then the 5th one is caregiver involvement. Like we said, a lot of times it's parent and child sessions where everybody's learning together about how to help here. Because it's very easy, especially we talked about all the signs and symptoms that adults experience, children experience those too. Outbursts, sometimes regression in some behaviors, some skills that they had before, they're regressing in a lot of those, how they're talking changes, sleep patterns. There's all these things that often occur in a company when children have gone through something challenging. And so this is a very specific, focused one for children and adolescents, because a lot of these other models are really focused on adults. And so this is one that's specifically geared toward kids and adolescents. So I'm very grateful there's something like this out there. I don't do a lot of work with children or adolescents, but this is a great model. It's a great therapy process. This is also something that requires a training. You can get trained in it. You can get nationally certified in it. I think the national certification for my research takes about 5 years. But if your intent and your desire is to focus on trauma work within children, this is a great model to adopt and get the most training possible in. So addressing trauma in the individual, these are just some considerations. When we're treating a trauma event in somebody individually, in the individual setting, obviously we've discussed the importance of establishing safety and trust, understanding trauma dynamics, one-on-one, that's going to look so different than it does in a group setting. Navigating the processing of trauma, again, having all those tools and those trainings and knowing how to help the client process effectively, fostering resilience, we've talked a lot about that, obtaining necessary trainings, and then reflect and celebrate. I think that's a big one because it's easy just to kind of get in the mud and the weeds of it all. that we forget to kind of take a step back and celebrate the even small wins. They did something they didn't think that they could do. They went outside and they thought that it was too unsafe to do it, or they were able to be in an environment and not get flooded or overwhelmed. These small things that we're teaching them through coping skills and through reprocessing and things like that, celebrating whenever they have wins that their trauma didn't affect them to where they couldn't function. Because again, we're trying to take the world from this. Trauma's taught them that this is all that they can handle, and their world gets very small to this. And the best way to do that is to help them celebrate the wins. Treating trauma in the group setting is a little bit different. We want to identify suitable participants. That is a necessity because you don't want someone in there that maybe their trauma is vastly different than what the rest of the group is experiencing, because they're going to feel more isolated and more alone. You want a participant that when they experience their trauma isn't too vast or different than everybody else. You may have a group of 12 where 11 of them, this is a trauma they've experienced a while ago. And then we've got somebody in there that it's fresh and it happened like 3 days ago. So suitable participants where everybody's going to get from the process and no one's going to feel isolated. Also, people that can withstand that and are stable enough to participate in a group setting. Again, creating safe and comfortable environment. Part of the environment creating is like, can you have comfortable seating and natural lighting, stuff that just kind of feels more less clinical. If you're group setting, there's a fluorescent light ahead and it's the most uncomfortable chairs you've ever sat on, probably not fostering the most comfortable environment to process the worst things you've ever experienced. So creating that comfortable environment is important. And I was taught this in EMDR training is we talk about safety a lot, and that's an important thing to establish. But sometimes individuals that experience trauma, safety is a really far out goal for them. And sometimes we got to watch our narrative and our language because we keep saying, well, how do you feel safe? How can you feel safe? And that's too far of a goal away from them. Nothing feels safe right now. And so we may modify that word and say, what can be more calming? What can be more helpful? So just something to consider. Establishing group norms and expectations and just group dynamics in general. Who needs to share a little bit more? Who needs to cut off? And then addressing individuals within the group setting. The best way I know how to manage those dynamics is, you're just kind of constantly maintaining the temperature of the room. And the person that's talking too much, how do you therapeutically move them on? How do you pull something out of someone that's not sharing enough? And then each individual is going to have their own experience. And the best way I know how to do that is so-and-so's talking, and then group, what do you guys think about? Who can relate? What do you guys think? What feedback would you give so-and-so? And so managing person individually sharing while incorporating the group as a whole. It's a whole different dynamic than doing it individually. So those are just some suggestions of doing each type. Considerations for treating trauma in the substance user. We're going to go back to those SAMHSA 6 principles and point out specifically what this looks like in a substance user and why it's even more important to look at it. The first one being safety. You've got a population of substance user where they are constantly in unsafe situations. Their sense of safety is really warped, and especially the experienced trauma, we've got a compounded sense of a lack of safety. They've been putting themselves in lots of dangerous situations because of their drug use. And so creating safety early on, that's going to be vitally important. And again, that's going to take some time for them to establish because, again, not much has been safe in their world and in their environment. Trustworthiness and transparency, something to consider in the substance use population is that trust is very low and it's warped. Their sense of trust is, well, who's going to keep my secret? Who's going to hide from me? Who's going to co-sign my negative behaviors? Who's going to not rat me out? Who's not going to flip on me? Those are all the ways that when you're in the drug and alcohol world, that's what trustworthiness is. And then you get to treatment and you start telling them, actually, ditch all of that. That's not trustworthiness. What trustworthiness is, are there people that can show up for you, that will be honest with you, that will hold your feet to the fire, that will tell you what you don't want to hear. That's people that are trustworthy. And so with this population, we have to redefine what trustworthiness actually is. And the thing with transparency to consider in a substance use population is they will expect full transparency from you, but you are not going to get full transparency from them, especially early on. I think once you develop the therapeutic rapport, that's going to shift and change. However, that is something to consider that you don't have to necessarily fully consider in other environments. I think a lot of people, regardless of what setting, it takes time to warm up to where you're going to be fully honest. But you're dealing with a population of people where it's been dangerous for them to be fully transparent. So maintaining some kind of mindfulness and awareness of that. Peer support is huge. We talked about that earlier because people know and understand what you've gone through. A thing I will add with the substance user is we're not just dealing with, it's not just helpful because people know what you've gone through, and that is cathartic and therapeutic. But also in the substance abuse population, we risk this concept of terminal uniqueness. What that means is they've got a disease of addiction that's taking over their brain, and the goal and intent is to keep them out there using. That's to isolate them, that's to pull all their negative thoughts, use it against them. And so we run the risk of having a population where they genuinely believe they're the only one going through that. People cannot understand them. People will never understand them because they've been black sheeps of their families or their school systems or their peers. And so they've really felt different for a long time. And so when we come into the treatment setting, it's a massive important thing to say, hey, you're not terminally unique. You're not so unique. Everybody's had this experience. And that's not to say you're not special and important and all those things. It's to say, if you believe you're that unique, you're going to go back out there and do this again. And then you risk the potential of dying out there. So it's important for them to understand there's nothing you've been through that someone else hasn't also been through. That's a very settling and grounding thing that helps them feel a little more established over time. Collaboration and mutuality, I would say the biggest difference in this with a substance user is they need a lot more direction early on. They are not the expert in their lives. They do not know what's best for them early on. So we run this really risky world of like, yes, they're the expert of their lives. However, they need a lot more guidance because they're just getting sober. They've had drugs compromise their world. They've been living in delusion for a long period of time, the delusion that this isn't a problem. And so collaboration can look a little bit different. Yes, we want to level the playing field where there's not this massive power differential, but you also want to conduct yourself and show up in a way in which they get the assistance that they need. They need a little bit more of a heavy hand, especially early on. So that's just something to consider in the substance use population. And then empowerment, voice, and choice. Again, this is a population of people where in my opinion, teaching them that choice is the biggest gift of recovery is an important message to kind of reverberate because they think they're out there until the delusion breaks. They think they're out there doing all these things and they're killing and everything's okay. Then the delusion breaks and they start seeing, oh, this thing has control over me. This population, the whole concept is built around you do not know what's best and you have to surrender and let go in order to move forward, which means you're not in control of everything going on in your life. That's a hard message. To balance that with empowerment, voice, and choice, you got to toe this really like fine line. We want them to have voice and choice, but what kind of voice and what kind of choice are we choosing? That's really hairy early on in recovery. I say the biggest gift that they have in recovery is the power of choice because actively using, there is no choice. They're going to keep using until something disrupts that process. And so when they get sober, they actually have choices I can use or not use. And that's the most powerful and empowering choice they'll ever have. And we want to build up that concept of like, this is why we got to get sober and live in recovery. And then also very similarly, better understanding the cultural, historical, and gender issues is an important piece when we're looking at the substance user because those play massive roles just like they do when we're just looking at trauma. So those are some considerations that might be a little unique to this population that wouldn't be as unique to other populations. The next thing we're going to be looking at is treatment planning. So the first thing, there's screening and then there's assessment. So how do we find and identify trauma in order to treat it? Screening processes are a big part of this. Screenings are just brief, formal processes that identify areas of the possibility of a problem. We do screenings for substance use and we can use screenings for trauma as well. Screenings help identify symptoms of trauma, past and present mental disorders, severity of symptoms, substance use disorder diagnoses, social and support coping styles. Within the Bradford network, they're doing the screening on the front end. They call in and someone is doing a screening with them to just kind of get some basic information so we can help determine what's going to be the most appropriate level of care for them, what's going to be the most appropriate treatment for them. So screening just gets basic information so we can see what all is going on that we can best help. Screening is an important part of being able to treat and help the substance user as well as those that have been through trauma. Assessments are a little more in depth and they really kind of look at the presence of a problem, determines its severity, and then we develop treatment recommendations from there. I put on here the common types of treatment assessments we use within our organization, and you probably have a lot that you use within your organization or your practice. The ones that we typically use to better understand their substance use as well as their trauma is the Adverse Childhood Experience Questionnaire. Ashley did a great job of explaining some of that earlier. And essentially, we're just looking at the presence of trauma before from ages 0 to 18. What was going on in their home? Were they exposed to trauma? Were they exposed to substance use in the home? That gives us a greater indication of what's going on with the client. Then we do a biopsychosocial assessment, and that's where we're getting everything. We are looking at their motivation for treatment. We're looking at their use history, their treatment history, their family history, their trauma history, education background, sexual orientation, spiritual beliefs, legal history, social and cultural norms. We're looking at all of this because as we're assessing, we want to pull out what all does this client need to work on, because that paints the picture for what are we going to treat in treatment. There are going to be some things we'll pull out and we can deal with in this setting, and then there may be some things we defer. For example, they got a lot of legal history, we may defer that to their legal counsel. If they've got a lot of trauma, we'll do what we can to develop the coping tools within the concept of what we do in treatment. And then we may make a really good referral for when they're done to continue individualized trauma work. So we do the psychosocial so we can see what else is going on. So that paints a picture for what we want to address in treatment. We also do the Columbia Suicide Severity Rating Scale. And a part of that looks at, well, what ideations and behaviors have they had in the severity of both? And then we're also looking at, well, what are activating events? For example, had someone come in that had suicidal thoughts about 3 months before they came here. Well, he'd lost both of his parents. It's an important thing to be able to know. Or someone, because that's a trauma event and it's all tied in together. And it helps us understand to create a safety plan that best meets their needs. So understanding that, a mental status exam, what is their thought processing? How are they showing up? What's their mood? What's their affect? Just kind of getting a baseline of how are they functioning when they walk in the door. And then we also do a brief addiction monitoring assessment. And that really looks at what was their last use, how's their sleep patterns been, how they've been able to manage emotions, or what level of distress do they have over arguments they're getting with family members. Do they have enough income to support the things that they're doing and their life moving forward? And so that's really just kind of looking at a monitoring assessment of everything going on. So assessments are just more in depth, and the sole purpose of assessments is so we can treat the individual. So then we move on to, well, how do we prioritize all of these problems? Because I know in our setting, and you, if you're in a private practice, that may look a little bit different. If you're working with children or adolescents, that may look a little bit different. But I think this model can help overall. It's just, we all learned this in a program. We learned it in our health and science classes. You may have learned it in your degree to get your license. But how do we prioritize? And I think using Maslow's hierarchy of needs is one of the best ways to do that. For example, if what we want to do is get in there with the client, be like, well, how can we help you deal with your trauma? How can we help you live a more effective life? How can we help you in your relationships and feel a little more secure in who you are as a person? Those are amazing goals. There's no way those goals are going to get met if that person doesn't know where their food is coming from that day. They don't have a place to live. Their housing is unstable. And so we use this level of care to prioritize, well, what are we going to address? Physiological needs are first. That is breathing, food, water, shelter, clothing, and sleep. It's really hard to help a client get to their emotional needs, like we said, if they don't know where their next meal is coming from or they don't have a safe and stable roof over their heads. So in the treatment process, we have to say, some of these other things that I might be more equipped to help you deal with your mental and emotional health. However, we might need to take a step back and actually meet these physiological needs first. The second one is safety and security. So health, employment, property, family, social ability. Again, these are things we build upon, and it's really hard to get to the place of, well, how can we help you feel more confident about yourself if they've lost their job, if they have financial insecurities, if their health is poor, or they have ongoing treatments they have to figure out how to get to. Again, prioritizing the needs, that sense of safety and security and meeting those needs first is going to be more important before the other ones. And then comes love and belonging. So what do your relationships look like? Your friendships, your family, intimacy with a partner, sense of connection. A lot of times in therapy, we want to jump there and start there, but it's important. Those first two categories are really important, and they can't get to those until they hit these other ones. But love and belonging, if you've got someone where their physiological needs are met, they're for the most part safe and secure, they may have some family dysfunction or their job may be on the line, but those areas are secure, then we can really look at that love and belonging. And then the next one up is self-esteem. So confidence, achievement, respect of others, desiring to be a unique individual. And then the top one is self-actualization. And that's where we want every client to get to. We want you to be living within your value system, to be engaged in your creativity, to be accepting and experience your world around you and have meaning, whether it's internal meaning or spiritual meaning. That's where we want everybody to get to. That's real far off if someone is homeless. And so understanding the needs that need to be met and prioritizing those appropriately. So I think using Maslow's hierarchy of needs is one of the best ways to help you prioritize, well, how do we treat substance use and how do we treat those that have experienced trauma? We got to get those needs at the bottom tier met before we can get to the top tier. Because again, it's going to be really hard to do trauma work if they literally, their water's being shut off and they're about to be evicted from their home. So just things to bear in mind. This explains this a little bit more. You can look at it in the slide. For the sake of time, I'm going to move on because we kind of discussed that when we were looking at the pyramid. Some points here on the prioritizing of presenting problems. The main thing is we got to work with the client to prioritize and using honest communication. I'll say that I'll give an example. I had a client who they wanted to do all of these things in treatment, and I said all of those things are absolutely amazing, but I think we got to be realistic. But what needs to be done first? We got to find you helpful housing after you're done here. We got to help you be. How can you not just be emotionally flooded all the time? And so I definitely want you to improve everything within your family system. However, being honest and saying, here's the reality of the things that we really need to look at and work with them to prioritize. This is a mutuality, this is opportunity for mutuality and collaboration. What do you want to work on? What's realistic within the concept of what you have going on in your life? Then we identify long-term goals from short-term goals. I had a client who he really desired to help the homeless at Christmas. Well, unfortunately, he's homeless right now. And so a long-term goal may be, I want to get into advocating and I want to get into helping others and being of service and all of those things. It's an amazing long-term goal. The short-term goal may be, well, let's get a state assessment done so we can place you in safe and appropriate housing when you're done with this level of care. And then getting feedback from supportive professionals in the field, whether you're an ALC or you're LMSW. I'm not as aware of social work degrees, and getting that support from your supervisor, from your work supervisor, and other people that you trust in the field. I've got friends that are also therapists that I talk with regularly, so also talking with them about how you can best utilize this. The last thing we're looking at here is post-traumatic growth. And just basically the purpose of this is once they've kind of done a lot of trauma work, well, what does it look like and how do they continue to grow? And the purpose of this is we want to have changes in how they relate to themselves and others. That's a main goal once they've done a lot of that heavy trauma work. And being able to recognize new opportunities, new ways of life, ways that they can take their experiences and maybe be helpful to others. A greater appreciation for the value of their own life and just life in general. Sometimes when somebody's gone through something really traumatic, they kind of come in and they have low value for their own life. And so once they've gone through the process and they've gotten into better spaces, there's just this greater appreciation and value for their life and how can they continue that throughout as they move forward. And then recognition of their own strength, and then spiritual or existential development. And I think a big thing that goes into this is building resiliency. We have a population of people with trauma users and trauma that have been affected by trauma and substance users. And it's just this ability to withstand and recover from whatever's happened. Again, life has taught us and trauma's taught us and substance use has taught us that it's this big and that's all we can handle. We want to broaden that out. And the best way we can do that is to prove, like, hey, you are capable. You can handle these things. You are empowered to move forward. We're going to push you and show you that you have the ability to do it. And so building that resiliency, because sometimes we get so caught up in creating a safe environment that we treat people, substance users and people that experience trauma, with kid gloves, which just reinforces the message that we're fragile, that they're fragile. And we want to move beyond that and actually develop a lot of resistance. Like, I know this is hard, but you can do it. I know it's hard to go out there and have that conversation, but you can do that. I know it's hard to use this skill so that you don't get emotionally overloaded, but you can do it. Because once they do it, then they feel more capable. And if they feel more capable, they're going to keep moving forward with it. And these are just a couple of resources before I hand this back over to Zach. The Body Keeps the Score is an amazing tool. It's a good one to give to clients too. It's just this concept of your body keeps and recalls what happens just as your brain does. There's a post-traumatic growth guidebook. These you can find on Amazon. It'll be in the slides that you can go back and look at. Then I attached a YouTube video of trauma-informed meditation practice. It's a great relaxation tool, these things that help calm a client down. And then the last one is just a network. This is a trauma survivors network. You can go to it, you can click and find all the resources in their area, or easily connect with groups online that can help support someone that's been through something traumatic. And there's my contact information. I appreciate you guys. I appreciate you letting me do this today. And I'm going to turn it back over to Zach.
Thank you, Leah. If you will advance one more slide, exactly right there. This is our contact information. I want to make sure everybody has a chance to get that if you don't already have it. Of course, we at Bradford have a 24-hour crisis line. If you or anyone, family, friends, or patients that you're working with need assistance seeking treatment for substance use disorder, we offer free consultation services 24 hours a day, 365. And of course, our website, bradfordhealth.com, where you'll find information about all of our programs across all of the areas that we operate in. Also, you'll be able to find articles and some other additional resources related to substance use disorder. And this is also an area where we keep up with our events page, which is how you learn more about fabulous sessions like the one we're just getting through with today. We're seeing the fluttering of all the thank yous coming in. I would also like to extend my personal thank you to both of our speakers today. We do have some time, just a little bit, so I'd love to. They've all been taking a little bit of a break now, but if they join me back, we're gonna throw some questions their way. To begin, one of the questions that we noted came in the Q&A had to do with the ACEs, the adverse childhood experiences. Now, as we learned today, Ashley provided a great overview of some of the background of this tool, and we carried that forward, and Leah referenced it a few times in terms of presentation and prioritization, things like that. But I think the question that, if I can sum it up as best I can, basically came down to because we set off this presentation with statements about how people perceive traumatic situations with a great deal of subjectivity. One can wonder why we use this standardized objective measure when it comes to ACEs, knowing that just because someone might have one, two, count however many adverse childhood experiences doesn't necessarily mean that they view that as traumatic. So I wanted to open that dialogue up, and we'll give Leah a break from talking for a moment while she catches her breath. So Ashley, do you want to field that initial question for us?
Yes. So the ACE really assesses the events that somebody may experience, but it's not, if we go back to the definition of kind of what's included in an experience, it deals with the person's meaning that they attribute to the experience and also their perception. That does not come from the ACE. So that's going to come from continued exploration with the client. But of course, we need a starting point for what we could explore, and that's going to come from the ACE. And so if we're looking at, individuals might not consider something traumatic, it might be because of the definition that they themselves give trauma. Oftentimes it's associated with like military individuals, or the experiences that they have might be intertwined in their life and it might be normal in their eyes. However, it might still have an impact on how they communicate or how they interact with others. So helping them explore that could be helpful.
Absolutely. I've always found the ACE to be a useful tool for those clinicians out there, especially those of you who are in private practice. If this is not a tool in your arsenal, please consider adding it. And there's great ways if you don't want to just hand over a 10 question questionnaire, which is all it is. You can pepper this throughout your other intake assessments. I think it can provide a lot of context. And like Ashley's talking about, there are several items on the inventory that some people might just not view as quote unquote traumatic. And some of it is kind of how societally we've talked about the big T trauma, capital T trauma versus the lowercase t trauma, which sometimes don't necessarily get recognized as having severe an impact as they do. And often we categorize things like divorce or loss of a friend or even a pet in those kind of lowercase t traumas, which actually kind of allows me to link to another question that we had. And again, to kind of wrap up what I'm interpreting the question to be is someone was speaking about how they might notice someone who's had relational trauma of some type. And they even use the example in their question of infidelity, how that traumatic experience they experience with one partner might carry forward into their future relationships. And I think that that's a very common experience, because I think that what we can see is some generalization of these experiences, and then and what I mean by that is generalizing into the next relationship, that all relationships are going to be like that. And then to a negative side of the spectrum, possibly even a self-fulfilling recreation of this. And what that reminds me of was something that Leah was speaking about related to kind of taking control of the chaos. And so I wanted to open that up to as an idea for feedback to both you, Ashley, as well as Leah, if she'd like to speak to any of that as maybe something that you encounter in the population you're serving.
Yeah. Oh, go ahead.
Specifically to the relational, carrying that into things you've experienced and carrying that into the next relationship, we see a lot of self-sabotage in this population. When something goes wrong, you start to think, well, it's always going to go wrong, or oh, here I am, I've done this again. And so what we can look at in the treatment setting is better understanding things like cognitive distortions, that overgeneralizing that Zach was talking about. There's lots of great CBT tools to say, again, like challenging those negative thinking to say, hey, is it that all your relationships have gone that way? Or upon reflection, and we're really looking at that, did you self-sabotage in any kind of way? Did you play any part in why that didn't go well in the next relationship? Also, it's a great opportunity to say, well, what's your value system and what are you looking for? We tend to attract what we're about. And if you're actively using, you're probably going to find other people that are actively using that are not in the best space, that are not living to their potential or struggling in some kind of way. And so it's a greater conversation to say, great, how do we get out of those processing? Because they're distortions at the end of the day. And we can't identify them as distortions until we can open up and be honest about them. Then once we do that, we have different tools to help kind of counter them and attack them and start proving that they're wrong, and that or if they're not entirely wrong, that they're funneled by some things that we can look at in a different way.
Leah, you were at the end of the presentation, you were speaking about the concept of resiliency. And I think that this topic we're speaking of right now kind of carries over into that very idea. Can you shed some light on the concept of what they call learned helplessness and how that might create that kind of self-fulfilling prophecy that we're kind of already speaking about here?
Yeah, absolutely. And, once you've had a hardship or you've experienced something, it's easy to believe, like we said, it's always going to go that way. And so then a lot of times learned helplessness also comes from the system around you. If you've got people that enable that and say, well, they're going through a hard time, so I'm going to do blank and blank for them. Or, well, we know why they can't show up well and effectively, so we're going to have a lot of empathy for them. And it's not bad to have empathy, but at some point we have to say, hey, in order to heal, in order to build resiliency, you have to have a sense of accountability and personal ownership and responsibility. And that's how we move toward empowerment. That's how we move toward actually being able to crawl out of learned helplessness, is to be able to look yourself in the mirror and say, hey, I am a part of the things that have happened here, especially in the substance use world. The 12 steps are beautifully designed to help people work through that. But until you can kind of see you're feeding into this in some way, shape, or form, it's a little trickier when you've been through trauma and it's trauma centered around that sense of helplessness. But even still, nobody likes to believe themselves to be a victim. But yet, if you're living life and doing things in such a way that you believe yourself to be helpless, then you're victimizing yourself at the very end of the day. And so, learning and gaining all the different tools to help people pull themselves out of that frame of thinking. And the best way you can do that is through those around them learning how to not enable as much, the clinicians in front of them be using honest and direct communication, and then pushing them to say, hey, personal ownership and responsibility, you played a part here. How can we help you play a different part now that you're sober or you're trying to help yourself or improve?
Fabulous. Thank you. During the initial part of the presentation, Ashley provided a very robust but succinct overview of some of the neurobiological aspects of the impact of trauma. I appreciate hearing that. It's definitely not my strength to speak about how the brain is necessarily impacted by all of these things. So I appreciated your ability to summarize that. I know we have a lot of clinicians in the audience, and they've probably heard a lot of these terms before. When you're working with a client, are there particular resources that you use to help provide that information, but in a digestible way that they can hear when they haven't had a psychology class or a neurobiology class of some kind before? So, what kind of tools in your toolbox do you usually go to for that?
Okay. So mostly I do rely a little heavily on talk or TED Talks, just because the presenters do connect it with research and terminology, but they also connect it to like a livable, understandable experience. And most of the time they do have slides that they're referring to as well. So one in particular that I was looking at earlier is Trauma on the Brain by Daisy Patton, Payton. That seemed to be, it's like 11 minutes, so relatively short. But of course, she talks about just the brain impact with very awesome graphics that are not necessarily specific to the brain. But also a book that Leah mentioned, The Body Keeps the Score, I think is really digestible. And I do recommend everybody reading that one. Of course, it talks a little bit more than just the neurobiology, because it's also talking about the body.
Great. All right, I'm going to open up this question to both, but we'll start with Ashley's response, if you don't mind. Question came but from a few different people. We're talking about trauma as an experience that we see in our clients a lot in this presentation. How do we keep ourselves as practitioners shielded from trauma from working with the clients and hearing about these things and getting in the trenches with them to help empower them? Maybe these can be some lessons that you can share from your personal experience of being in the field for as long as both of you have, but maybe also anything that you've come across in the research that can help us to learn.
Okay, so I'm going to say three things. Your own counseling. So I think it's very beneficial for especially everyone to have their own counselor, but I think it's specifically beneficial for people in this field because we are exposed to a lot of different things. And of course, secondary vicarious trauma, burnout, things like that can happen. The second one's going to be your own self-care. So making sure you're, engaged with social support, your environment, that you have a home life outside of work, coping skills and hobbies of your own. And then the third one is coworkers. Teamwork makes the dream work, as people say. But having the ability to talk about hard cases and to get things out in the open and to process those with your coworkers is going to be a great resource, and I mean a very easy thing to do because you're already surrounded by your coworkers. So those would be my 3 suggestions.
Wonderful. Leah, anything to add to that?
Those are great ones. The only thing I would say is be willing to do what you suggest your clients to do. We suggest our clients to use coping tools and utilize therapy and peer support and the support groups around them. And so, not being hypocritical and saying you do these things, but I don't have to do these things, because it's just a field you're constantly hearing things, even if you're not hearing trauma every day. Especially in our substance use world, we're hearing no one's coming in a good spot. You're catching people on their worst day. And so really developing your own resiliency, but also enough separation between you and them, to where, enough tactics. I think sometimes when I leave work, I'm like, as I'm walking through the threshold, I'm like, okay, I'm leaving work and I'm moving into my home life. And I know it's kind of weird, or when I'm turning on music, that's a signal to me that this is the end of the day. Just these things that you tell yourself to kind of create some mental separation, if that makes any sense.
Yeah, it does completely make sense, and it is a purposeful act. And yes, I've heard many people talk about they actually have a ritual around this, like when I put this song on, or whatever it is, when I get in the car, or when I pass this road, I know it's behind me. Yeah, I think that's great. Um, the only comment I'll add to these, which is fabulous, is, and this is speaking to all of our audience. I think, especially if you work in an agency setting or in a hospital type setting, this can feel very much more pronounced because, as Leah talked about, you're kind of only seeing people in a very slim window. You're seeing them in the crisis. You're helping getting some resolution, but in general, treatment is relatively short term. Now, we operate on a continuum, but if you're working in residential where you're working with them for a few weeks, a month maybe, you're only getting them so far. Yes, we step down to lower levels of care. Some of you who work in private practice get the opportunity to see people, over the course of years and see real sustained growth. In an agency setting, that can be challenging because you don't always get to see how far they truly go after they're out of your care setting. So please use the resources that are out there. We all have that shared experience if you work in this field long enough of understanding those pitfalls that do happen. So, yes, ma'am.
Not getting caught up in the results. You show up and you do your best and you give what you have to give. I tell my new clinicians this all the time. You can't get caught up in the results because there's so many variables in their home life and the things they've been through, and some things we know and some things we don't know, that if we get caught up in the results, if they do better, then yay, good on us. But then if they don't do well, then that means something about us, and creating that separation of you're there to show up and do a job and do the best you had to do and give them the skills and the training that you have. But then remove the successes and the wins and the losses. That's on each individual person. So, yeah.
I think that's a great comment to end on. For those of you who are asking in the chat about the survey, we've linked it in a few times. You'll notice it is in the Q&A. We just had our colleague Sherry put it back in the chat right there. If you want to grab it, it is there. It will be in the post-survey email that will be coming your way, as well as links to this recording and to the PowerPoint itself. Thank you very much again to our presenters, Ashley Phelps and Leah Parker. It's been a very informative session. This concludes all of our trainings in this series for 2024. We hope to see you again in 2025 with an additional offering of yet another refreshed series of new topics and new presenters. And you have an opportunity to give us some feedback about some things you'd like to see in the future. That'll be in the survey as well if you haven't already taken it. Have a wonderful, blessed December holiday season. And again, we'll see you again in 25.